Good evening, everyone. We welcome you all to OrthoTV online Ortho Excellence series. And to introduce today's topic and the speaker, I hand over to our moderator, Dr. B. Shiv Shankar, President-elect, Indian Orthopedic Association. Over to you, sir.
Good evening, Dr. Neeraj. Welcome all for today's Ortho Excellence Series webinar on analysis of the ulnar-sided wrist pain by Dr. Abhijeet Wahegaonkar from Pune. We also have panelists in the form of Dr. Anil Bhatt, Professor from KMC Manipal, Dr. Praveen Bharadwaj from Ganga Hospital, and Dr. Pankaj Ahire. To introduce our speaker today, Dr. Abhijeet Wahegaonkar is adjunct professor of hand surgery, distinct clinical tutor of orthopedic surgery, director upper limb hand and micro surgery fellowship program, consultant and head at Department of Upper Extremity Hand and Microvascular Reconstruction Surgery, Sancheti Institute of Orthopedic and Rehabilitation, Pune, as well as Jahangir Hospital, Pune. He has 36 peer-reviewed publications. He has authored 12 chapters in textbook. He has read more than 300 papers and he has given more than 60 invited talks at both national and international levels. He is also working as visiting professors at Shahid Beheshti University, Tehran, University of Strasbourg in France, and IRCAD in Taiwan. He is the founding president of Wrist Society of India. He is also member of American Society for Surgery of the Hand, French Society for Hand Surgery, European Wrist Arthroscopy Society, International Wrist Investigation Workshop, founding Executive Council member of the Asia Pacific Wrist Association and chairman of the IT Committee, Executive Committee member of Maharashtra Orthopedic Association, and is the chairman of the Fellowship Committee of Maharashtra Orthopedic Association. Welcome, Dr. Abhijeet. We have expert in the form of Dr. Professor Anil K. Bhatt. He is Associate Dean and Professor and Unit of Hand and Microsurgery in the Department of Orthopedics at Kasturba Medical College, Manipal. He is the Chief Coordinator, HASTA, the Center for Congenital Hand Differences, Manipal Academy of Higher Education. He is Coordinator for 3D Printing Center of Hand Prosthesis for Children at Artificial Limb Center at KMC Manipal. He is the Chief Editor, Journal of Karnataka Orthopedic Association. He is also PhD guide registered in Manipal University. His special area of interest are hand surgery, wrist disorders including wrist arthroscopy, congenital hand differences, tendon reconstruction, elbow disorders, and sports injuries of upper limb, as well as endoscopic carpal release. Welcome, Dr. Anil Bhatt, sir. We have another expert from Mumbai, Dr. Pankaj Ahire. He is working as a hand and upper limb surgeon at Godrej Memorial Hospital, Nanavati Hospital, Holy Spirit Hospital, and Saipi Hospital, all in Mumbai. He is Honorary Secretary of Indian Society for Surgery of the Hand. He is the member of Bombay Orthopedic Society, member of American Society for Surgery of the Hand, member of International Wrist Investigators Workshop. His area of special interest are wrist trauma, wrist arthroscopy, and sports injuries of the upper limb. Welcome, Dr. Pankaj. We have another expert in the form of Dr. Praveen Bharadwaj from Ganga Hospital, Coimbatore. He has passed his MBBS from KMC Manipal. Then he has done diploma in National Board in Orthopedics in 2004. Subsequently, he did fellowship in hand and micro surgery from National Board at Delhi in 2009. Then he has completed European diploma in hand surgery from the Federation of European Society for Surgery of the Hand in May 2011. Though he was brought up in Delhi, he started his career in Kasturba Medical College, Mangalore as assistant professor of orthopedics. His passion for hand surgery brought him to Ganga Hospital, where he joined as a fellow in hand surgery, hand and microvascular surgery in 2007. After completing his fellowship in 2009, he continued to work in Ganga Hospital in various posts. Now he is associate consultant in hand and reconstructive microsurgery at Ganga Hospital. His special interest areas are wrist surgery, birth brachial plexus palsy, adult brachial plexus injuries, cerebral palsy, paralytic upper limb, nerve injuries, and reconstructive microsurgery of the upper limb. Welcome, Dr. Praveen. Friends, we also have Dr. Neeraj Bijlani and Dr. Ashok Sham from the OrthoTV. Now, I welcome all the expert panelists as well as the speaker today, Dr. Abhijeet Wahegaonkar, for his talk, Ulnar-sided wrist pain. Everything that hurts is not EFCC. Over to you, Dr. Abhijeet.
Thank you very much, sir. And it is with a lot of caution and with a lot of trepidation that I'm going to speak about ulnar-sided wrist pain, especially when I have my friends, dear friends and colleagues to serve as such erudite panelists. I am unable to see the share screen.
6 o'clock position. First, you click on the zoom. You minimize the zoom, maximize it by.
Already, yeah, minimized, and I can't. Yeah, share screen. I got it. Sorry about that. Right in front. I'm so scared right now. You know. All right. So this is a topic, and Shiv Shankar sir, thank you so much for your leadership in organizing this webinar. And my task today is to talk about ulnar-sided wrist pain. This is a topic which is very dear to my heart and has always intrigued me as a fellow, continues to challenge me in my clinical practice today. So without further ado, are you able to see my?
Yeah, we can see your presentation. Oh,
okay,
it has gone into again.
Yeah, it's hung up here. I'm very sorry about this. Give me a moment. There's some problem here. So stop share for a moment. Just give me one brief moment, please.
Yes. Let me ask meanwhile one question to Dr. Praveen Bharadwaj. Praveen, what are the causes for ulnar-sided wrist pain? You have to unmute and speak.
Yes, sir. So I think when it comes to ulnar side wrist pain, the most easy way to classify them are intra-articular and extra-articular type of pains.
Yes.
So that straight away simplifies our analysis of them because.
Yes, Abhijeet, you can make full screen. Meanwhile, you can check. Yeah, that's fine. Yeah, I think we'll get back to you, Praveen, little later.
Yes, sir. Sure.
Yeah. Yes.
Thank you. Sorry about that glitch. So as I said, my task is to talk about ulnar-sided wrist pain, which is a very common clinical condition that each one of us as orthopedic surgeons will encounter in clinical practice. And this is going to be the brief outline of my talk, where we're going to introduce the concept of ulnar-sided wrist pain, understand the anatomy and the biomechanics, the different structures that are responsible for ulnar-sided wrist pain, learn a little bit about the classification, the treatment algorithms or the recommendations, and understand reparative, reconstructive, and salvage procedures for these problems. So what is it that is so peculiar about ulnar-sided wrist pain? One, it is a very common clinical problem. Two, it is very disabling for the patient. So anyone who has seen a patient or has had ulnar-sided wrist pain sometime in life will appreciate how disabling even slight pain can be. It is difficult to understand because there are a myriad reasons why you may have or your patient may have pain on the ulnar aspect of the wrist joint. It is difficult to treat. More often than not, because the pathology varies with every few millimeters, and understanding the root cause of the pathology, the anatomical structure that is responsible for the pain is of utmost importance in effective treatment. So again, that is one more treatment dilemma. It is difficult to treat. It is often referred to as the black box of the wrist joint. and also has been called as a low backache of the wrist joint. So it is very common, disabling, difficult to understand, and difficult to treat. And all of this poses challenges in our clinical practice. Let us understand a little bit of anatomy and function of the ulnar wrist joint. So this schematic diagram will help you understand that the DRUJ, or the distal radio-ulnar joint, is not one single entity, but is comprised of the distal radio-ulnar joint aspect, the forearm complex, and the proximal radio-ulnar joint. And all of these are responsible for the function that we are able to perform with the hand. So we have to first and foremost recognize that the distal radio-ulnar joint pathology is often linked to proximal problems. Very common example that we may recognize is the Essex low-crustal lesion, for that matter. A good way for orthopedic surgeons to understand the DRUJ is to understand or use the analogy of the knee joint. So we have the medial compartment, you have the lateral compartment, and the interossei ligament, the cruciate ligaments. Likewise, if you were to think that this is the lateral or the medial compartment, this is the other compartment, and you have the cruciate ligaments, which represent the interosseous membrane in the forearm. So these are the aspects of the forearm, and whenever there is any load, the compressive or shear load, and if there is any pathology or ligament injury here, you would have pain and dysfunction at the distal radio-ulnar joint. The osseous anatomy also is very peculiar for the distal radio-ulnar joint. There is a very shallow sigmoid notch on the medial aspect of the radius. This is dorsal, this is volar, this is the Lister's tubercle, and the sigmoid notch is represented here, wherein the head of the ulna will be seated. So not only is it shallow, the articular surface is also pretty small in comparison to the large articular surface of the distal ulna. So the seat of the ulna, or the articular surface of the ulna, is pretty large as compared to that of the sigmoid notch. So this inherently is an unstable joint, and therefore the stability of the DRUJ, or the distal radio-ulnar joint, depends largely on structures other than the osseous anatomy. So you have extrinsic and intrinsic entities that stabilize the distal radio-ulnar joint. So you have the ECU groove, the extensocarpi ulnaris groove on the dorsal aspect of the ulna, which is represented here. And if you look at the axial section, which is shown in this slide, you will appreciate that the very small articular surface, or this of the sigmoid notch, accommodates a very large head of the ulna. So this is akin to, people have given the analogy of the tire on the road. So if this is the road, you have a large tire, and therefore point contact pressures can be pretty high at different aspects in the range of movement of the DRUJ. And besides that, you have compression forces as well as shear forces, which are trying to disrupt the joint. And then the ligaments and the structures around the joint will stabilize the joint, imparting the kinematics and the kinetics of the joint. We already talked about this, and this is how it is represented in geometrical figures, where you have a large ulnar head sitting on a relatively shallow sigmoid notch. And therefore, because of this osseous mismatch, you have great translation. So whenever there is a pronation and supination movement, the ulna will translate dorsal and volar in relation to the radius. And rotation obviously is responsible for your pronation and supination. So what are the different structures that we come across that stabilize the distal radio-ulnar joint? So first and foremost, and almost everyone will talk about the triangular fibrocartilage complex, or the TFCC. And whenever I'm talking to my patients, I make them understand the concept of TFCC in a very simplistic manner. Triangular because of the shape of the structure. It is like a triangle. Fibrocartilage is the content of the structure, and complex because there are several, it is not one single entity, but several entities that merge into the structure to form the structure. A lot of investigators have devoted their careers and lives to this particular structure alone. And notably, one of them is Dr. Nakamura from Japan, who talks about this particular structure like a hammock, which is hooked on to the fovea at this particular juncture here. So in this particular slide, we have the carpus that is flipped over, and this is the lunate and the scaphoid here. This is the lunate fossa. This is the radius fossa. This is the styloid of the radius. And then we will be able to appreciate the triangular fibrocartilage in a cadaver section, which inserts on to the fovea, the base of the styloid process on the ulna, and the sigmoid notch on the radius. We will understand a little bit more about this in the subsequent slides. So this particular structure is one of the primary or the key stabilizers of the distal radioulnar joint. And this particular section is a very famous slide that comes from the work of Dr. Toshiyasu Nakamura. And this is a fetal wrist. And here we have conclusively now shown and studied that the TFCC has a very firm attachment onto the base of the fovea through Sharpie's fibers. And this attachment is perhaps the most important aspect of the TFCC. The distal aspect of the TFCC has got insertions onto the soft tissue. Therefore, the proximal attachment is thought to be the most important and the most robust attachment of the TFCC onto the fovea. Besides the TFCC, you have radioulnar ligaments, which are classified as palmar radioulnar and the dorsal radioulnar ligament. These are ligaments that attach the ulna onto the radius again and to the volar and the dorsal corner respectively. And again, they reinforce the stability of the distal radioulnar joint. And these are distinct ligaments from the triangular fibrocartilage complex. Although it merges with the TFCC, the radioulnar ligaments also are important stabilizers of the DRUJ. There are extrinsic contributions, and perhaps the most important extrinsic contribution is from the extensor carpi ulnaris subsheath. This is a distinct fibrosseous subsheath that stabilizes the distal radioulnar joint. This arrow demonstrates the ECU which goes through this fibrosseous tunnel here, and the subsheath is responsible for stabilizing the distal radioulnar joint. Besides the ECU subsheath, we also have the capsule of the distal radioulnar joint, again, which is a distinct entity. And this also contributes, like any other synovial joint, to the stability of the distal radioulnar joint. Now, all these ligaments that we talked about stabilize the radioulnar axis. We also have ligaments or structures imparting stability to the ulnocarpal axis, and these are the ulnocarpal ligaments. And in this particular slide, you will see the central aspect of the TFCC has been removed. You can see the ulnar head through the axial end-on view and the sigmoid notch and the fovea. This is the dorsal radioulnar ligament and the proximal radioulnar ligament, the palmar radioulnar ligament. And the ulnocarpal ligaments are extensions which merge on to the volar or the palmar radioulnar ligament. And these ligaments impart stability to the ulnocarpal axis. These are histological images of the same structures that we saw anatomically. Which are these ulnocarpal ligaments? They are the ulnolunate, the ulnotriquetral, and the ulnocarpal ligament. So let these names not confuse you. Just to reiterate, you have the triangular fibrocartilage complex, you have the radial ligaments, you have the joint capsule, the ECU subsheath, and the ulnocarpal ligaments, which are the key ligaments in stabilizing the carpus on the forearm axis and stabilizing the DRUJ as the wrist and the forearm is carried through a range of movement. So the key concept, and this is especially for every orthopedic surgeon to understand, that the DRUJ is a load-bearing articulation, pretty much like the knee joint, pretty much like the ankle joint, pretty much like the hip joint. The distal radioulnar joint is a load-bearing articulation. Once you understand this, it just makes things very easy for us to comprehend and to deal with these particular problems. So how is DRUJ a load-bearing joint? If you look at this schematic diagram, where you see the forearm axis and the ulnocarpal axis, we will understand after we remove the superimposed schematic diagram of the forearm, you have a link between the radius and the ulna proximally and distally. This is proximal and distal, and you have the carpus here. So whenever the forearm goes through a range of pronation and supination, it is a radius that is revolving around the ulna with these articulations remaining intact. So here in this schematic diagram and animation, we'll understand the shear forces and the compressive forces that this joint is subjected to. And we are looking at it in the frontal and the axial plane at the same time. So as the forearm comes from supination to pronation, in this it is completely supinated. The ulna remains stable and the forearm rotates around the ulna. In this position, there are a large amount, a huge amount of shear forces that are trying to pull the radiocarpal axis towards the gravity or towards the direction of the force. And there are almost no compression forces across the radioulnar joint, the distal radioulnar joint. As the pronation starts and the radius of the sigmoid notch starts to cover the distal ulna, you have some increase in the compression forces, some reduction in the shear forces. And then in the mid-prone position, there is a further change with reduction of shear forces, increase in the compression forces. And in the absolute mid-prone position, there are almost no shear forces because the ulna is bearing the brunt of the entire radiocarpal axis. So in this particular position, you will see that there are immense compressive forces across the distal radioulnar joint. And then with further pronation and in full pronation, again, the DRUJ is subjected to a large amount of shear forces with no compression forces in this particular position. So what is it that mitigates the compressive loads? It is the brachioradialis. The brachioradialis is helpful in mitigating some of the compressive loads, if not in toto. And the shear loads are mitigated by the triangular fibrocartilage complex. And this is a dynamic entity rather than a static entity where the different aspects of the ligament will relax and stretch in different positions of pronation and supination. And we won't belabor too much on those biomechanics. So in summary, stabilizers of the DRUJ are denoted in this particular slide. They are the TFC, the ulnocarpal ligaments, the ECU tendon and the subsheath. The tendon is a dynamic stabilizer, the pronator quadratus muscle, the interosseous membrane, and the capsule that we talked about a little while ago. So let us understand the TFCC in a little bit more detail. We had already talked about this, showing the Sharpie's fibers as a very important contribution for radioulnar stability. This is not working. I'm sorry about this. This is a cadaver specimen again, and it shows the TFCC in great detail. This is the lunate, the scaphoid, the radius, the triquetrum. So here you have the TFCC going all the way. This is the distal aspect of the TFCC, whereas the proximal aspect of the TFCC has a nice, strong insertion onto the base of the fovea. And this insertion is key to maintaining stability of the TFCC. So here is another schematic diagram with the capsule opened out to show you the TFCC. This is the head of the ulna, and this is the triquetrum here. This is another schematic diagram to show, unfortunately, this is not working. I'm sorry about that, I apologize. But this histopathological tissue staining corresponds to the cadaver specimen on the right-hand side. After having understood the fibrocarp, the TFCC, let us now take a look very quickly at the ulnocarpal ligaments. Like I mentioned earlier on, the ulnocarpal ligaments merge on to the volar radioulnar ligament. And there are two key ligaments that we identify and talk about. And these are the ulnotriquetral ligament and the ulnolunate ligament. So these ligaments are important in stabilizing the ulnocarpal axis. This is a sagittal view of the same concept, wherein these ligaments are highlighted and shown as to how these ligaments will stabilize. If there is a tear of these ligaments, we see a typical palmar sag of the carpus, and we'll see that in subsequent slides. If you look at the carpus and the forearm in an end-on view, you will understand that these ligaments, when they are torn, there is a carpal sag. So the ulnocarpal ligaments are intact here. And when these ligaments are torn, the carpus supinates and subluxates over the radioulnar axis. And this is the classical deformity of the palmar sag that you can see here. Pretty much like the posterior sag of the tibia on the femur when the anterior cruciate ligament is torn, if that helps you understand this concept. Let us now look at the extensor carpi ulnaris tendon and the sheath. This is an axial cadaver section, and you can see the extensor carpi ulnaris here and a very nice distinct subsheath in the fibroosseous tunnel. This subsheath, through the dynamic action of the extensor carpi ulnaris, will help stabilize and prevent dorsal subluxation of the distal radioulnar joint. So this is another cadaver specimen to show you the sheath having been opened out with the extensor carpi ulnaris. This is the fifth compartment comprising of the EDM and the EDQ, whereas this is the ECU and this is the sheath, and the subsheath is underneath the ECU in the groove that we saw a little while ago. So how does the ECU stabilize the DRUJ? Is by the pull of the extensor carpi ulnaris. It brings the ulna closer to the radius and stabilizes it. The pronator quadratus muscle is also, although it may come as a surprise to a lot of you, but it does play a very important role in stability of the DRUJ. And therefore, as hand surgeons, we always like to repair the pronator quadratus after we have done something for the distal radius for that matter. So we should appreciate, so this is the volar aspect of the forearm with the flexor tendons removed and only the pronator quadratus being seen here. So this is the distal edge on the watershed line of the radius and the proximal edge. And you can see that there is a nice robust tendinous origin of the pronator quadratus. So in pronation and supination, the pronator quadratus acts as a dynamic stabilizer of the distal radioulnar joint. So whenever we have supination and pronation, the muscle will bring, due to its contraction, will pull the ulna into the sigmoid notch and thereby stabilize the distal radioulnar joint. And last but not the least is the intraosseous membrane. And this has been recently studied by Dick Berger from Mayo Clinic. And he has shown that the distal oblique band, which is being highlighted here, is one of the key stabilizers of the distal radioulnar joint. And it is therefore recommended whenever you're doing a Darras procedure or a Sauvé-Capondji procedure, not to do too proximal a resection of the ulna for the risk of creating DRE instability. So as long as this insertion is respected, the proximal stump will have relative stability in comparison to too proximal a resection of the ulna. Now, this particular section, cadaver image, will show you the middle band of the interosseous membrane, which is inserted like in a Z-like manner, and it allows for a little bit of translation of the radius as the forearm goes into pronation and supination. And therefore, when this ligament is torn as an SX lopresti, there is a proximal migration of the radius that can occur. So with that background of the anatomy and the biomechanics, let us come to the topic at hand and painful disorders of the ulnar wrist from the clinical standpoint. So let us understand what the different reasons or causes for distal radioulnar joint pain might be. So beginning with soft tissue injury, any injury to the TFCC per se, to the distal radioulnar ligaments, or to the ulnocarpal ligaments, or to the joint capsule, or to the extrinsic tendon mechanism, whether the flexor carpi ulnaris or the extensor carpi ulnaris, will cause pain on the ulnar aspect of the wrist joint. So this is a pretty intuitive kind of a slide. All these soft tissues that we talked about a little while ago, any injury, it may be a strain, a sprain, or a complete tear of the ligament, will result in varying grades of instability associated with pain. What about the articular surfaces? So the articular surfaces, will that be of the ulnar head, the sigmoid notch, the ulnar carpus, and of course the pisiform. Although it is not a direct part of the wrist joint, the pisotriquetral joint, if there is any problem with this joint, will result in ulnar-sided wrist pain. So fractures of the head of the ulna, any injury to the sigmoid notch articular surface. So this is especially when there are comminuted intra-articular fractures of the distal radius involving especially the ulnar corner. Fractures or injuries of the triquetrum or the lunate. Chondromalacia from an ulnocarpal abutment syndrome is another example. All of these will result in ulnar-sided wrist pain. So the etiology of distal radioulnar joint injury or ulnar-sided wrist pain can be from trauma. These are usually a result from a fall on an outstretched hand, which results in torsion with axial loads. There may be a developmental variance, and the typical example of this is the Madelung deformity. You may have inflammatory arthropathy such as that seen in rheumatoid arthritis. The spectrum of injury can vary from only ligament injuries or soft tissue disruptions involving strains, sprains, or complete tears, fractures of the distal radius or the ulna or the carpal bones. What is of pertinent importance is that almost 50 to 60% of distal radius fractures will be associated with some kind of a ligament injury. So this is something very important for us to understand and identify and remember. An extension of perilunate fracture dislocations also is an important cause of injury of the distal radioulnar joint and resulting in pain on the ulnar side of the wrist joint. So with that background of different etiology, how do we diagnose and evaluate ulnar-sided wrist pain? Obviously, a thorough history is of paramount importance. I need not belabor too much on that. Mechanism of injury, if any, you need to take into account the hand dominance and the occupational history. We need to take into account any aggravating factors that increase the pain or relieve the pain. You also need to understand the patient's recreational and professional sports activities. So with that history behind us, we embark on a clinical evaluation, which begins by inspection for any swelling, ecchymosis, open wounds, any deformity. We palpate for localized tenderness. It is very useful to follow a set pattern of examination. And we begin from dorsal and we move on to ulnar and then to volar usually. We begin from proximal and move on to distal. Any attempt to reproduce the symptoms by stress examinations that we'll come to in the next slide. And very, very important is to always examine and compare it with the contralateral unaffected wrist. So a lot of times people may have constitutional laxity, and we should not think of one wrist that is painful because of some other reason to be a TFCC injury when laxity is a reason for the instability pattern. There are certain provocative tests that have been described in literature. These involve the piano key test, the PC-form boost test, the ulnar compression test, the ulnar grind test, the piso-tricutal grind test, the DRUJ ballotment test, the lift-off and the compression test, and evaluation of the extensor carpi ulnaris. So all of these tests or clinical examination tests will give you an inkling as to where exactly the pathology is lying, and therefore you can zoom in or narrow in your diagnosis, combining your clinical examination with a good detailed history that you have already elicited. This is a classical DRUJ ballotment test, and under anesthesia, it is pretty remarkable that the DRUJ is much more unstable than when you're seeing the patient in your clinic. Once you have your clinical examination behind you, obviously you have a set of differential diagnoses, and you would like to investigate the patient by ordering a set of investigations. And these are obviously plain X-rays to begin with. You would look for any trauma, erosions, joint integrity, ulnar variance, and we always advise a view which is called as a neutral view of the wrist joint. And this is with the shoulder in 90 degrees abduction, with the elbow in 90 degrees flexion and the wrist in neutral, and you take a PA view in this particular position. This is the only view which will give you the correct assessment of the variance of the ulna. And then obviously you would take a view in ulnar deviation, radial deviation, a lateral view, an oblique view, and a clenched fist anterior-posterior view. And once you have a good look at the X-rays, you would perhaps not need any further studies, but in view of the recent advances and to zero in on the diagnosis and provide more clarity, you may advise an MRI to detect any ligament defects, especially injuries to the triangular fibrocartilage, bearing in mind that there may be false negatives and at times even false negatives. A fluoroscopy also is useful. However, we should keep in mind the increased exposure to radiation. Ultrasound examination, and I'm sure Professor Anil Bhatt will enlighten more on this because he has a very large experience on the use of ultrasound and diagnosis of wrist joint pathology, is again a very important adjunct to your armamentarium of investigations. Arthrography is perhaps a thing of the past, but our European colleagues rely a lot on CT arthrograms, bone scans at times, and a CT scan, of course, for some injuries involving fractures and dynamic instability. Now, in spite of all the investigations that we talked about, arthroscopy perhaps remains the gold standard because it gives you the opportunity to visualize the joint in every nook and corner, to dynamically evaluate the ligaments, to look at the cartilage surfaces, and also to combine it with some kind of a therapeutic intervention. Let us understand the classification. There are several classifications that have been published in literature. There is the Bowers classification, there is a Mayo classification, the Palmer classification. As you can see, it is a pretty confounding type of classification and may not be very easy for us to remember. So I like to look at ulnar-sided wrist pain in a very simplistic manner. And this was something that was propagated by Dr. Dick Berger from Mayo Clinic. And he described the ulnar-sided wrist pain as those patients who present to you with pain, or a cohort of patients that would present to you with pain and instability, or pain with arthrosis. So this rather simplistic classification is pretty useful in determining how you would go about dealing with these patients, and we'll understand in a little bit. But before we do that, here is another suggestion that was propagated by Mark Garcia Elias, and this is a very useful clinical adjunct in determining what we need to do. So we need to take into account whether the TFCC is repairable or not, whether the cartilage is intact or not. And you have the stable where yes, no kind of a thing. So let us take the first scenario where the TFCC is repairable and the cartilage is intact. You would go ahead with a reparative procedure. This may be open, arthroscopic, using anchors, using capsuloligamentous repair, whatever. So a repair is possible or should be performed when you have a repairable and a good tissue of the TFCC along with the cartilage that is robust and intact. If the cartilage is not, if the TFCC is not repairable and the cartilage is intact, we would recommend a reconstructive procedure. A very classic example is a tenodesis procedure using a palmaris longus tendon graft, and that is the Adam-Berger procedure, which was initially described by the Mansat brothers way back in 1983, even before this was popularized by Berger and Adams. Stage 3 is when you have a repairable TFCC, but the cartilage is not intact. And that would call either for a partial implant if that facility is available, or for a salvage procedure. And in the scenario where the cartilage is damaged and the TFCC is not repairable, you would go in for salvage procedures. And we'll talk about that in a little bit. So we already talked about this particular situation where the patient presents to you with pain on the ulnar aspect of the wrist joint, and you find that the pain is the only issue with no instability. Then you look for the fovea sign. This fovea sign was again described by Dr. Richard Berger. Essentially, you look for tenderness in the ulnar snuff box in supination. So this is the pisiform, this is the flexor carpi ulnaris, this is the styloid process. So you palpate the soft spot medial or ulnar to the flexor carpi ulnaris, and on deep palpation, if there is pain, that would represent a tear of the ulnocarpal ligaments or that of the TFCC. So this is very specific and sensitive for split tears of the ulnar-lunate ligament and foveal dissociation of the TFC. However, there is low differential specificity, and if positive, an arthroscopy is advised to differentiate between these two and deal with them in a minimally invasive manner. Obviously, imaging will also give you the idea as to what is happening. So if you see that there is subluxation or an ulnocarpal subluxation, that would couple it with a clinical examination to clinch the diagnosis. So pain alone, a very common example that we see is a central tear of the TFCC. An arthroscopy is a very good way to diagnose and to treat this, pretty much like the meniscus of the knee joint. You would debride, shave, and stabilize the TFCC to a stable rim, and that would pretty much take care of the pain. You need to be sure that the ulna is of neutral variance. If there is a positive ulnar variance, you would usually do either an ulnar shortening osteotomy or maybe an arthroscopic Felden procedure, as we'll see in the subsequent slides. Another cause of pain is tear of the ulnocarpal ligaments, usually vertical splits. These are vertical splits that are shown here that will cause only pain. If there is a transverse split, that would result in instability and pain. These are again dealt with arthroscopic debridement and shrinkage. Capsular stretch is another common cause of pain in the ulnar side of the wrist joint, and tear of the lunotriquetral ligament at times also can cause pain on the ulnar side, although very rare. Synovitis from various causes, inflammatory or infective also, or traumatic, may be a cause of pain, isolated pain without instability. Let us come to the second scenario where you have a cohort of patients who present with pain and instability. And these patients are those who have a tear or a complete avulsion of the radioulnar ligaments, or a foveal disinsertion of the TFCC, or a transverse tear of the ulnocarpal ligaments, or a complete tear of the joint capsule, or a subluxation of the ECU subsheath. So these are the patients who will have pain with instability. And how do we deal with that? With these patients, we'll just come to that in a little bit. You may also have pain that is associated with or without arthrosis. A typical example is a positive ulna resulting in an ulnar impaction syndrome. And this is a slide that is showing an arthroscopic view. We have a central perforation of the TFCC here, through which the head of the ulna can be seen, and you can resect the head of the ulna using burrs and shavers while retaining the cartilage in the sigmoid notch and the ulnar aspect and the head of the ulna. So this will resolve the conflict between the ulna and the lunate. So here you can see the ulnocarpal conflict, and here you can see the resection of the ulna in a minimally invasive manner, and that will give you the desired pain relief for your patient. Ulnar shortening osteotomy is another way to deal with ulnocarpal abutment or a positive ulna. And this is a post-traumatic malunited distal radius. And you can see that the ulna is proud with an ulnocarpal abutment. You can see a small cyst that is forming in the ulna, and an ulnar shortening osteotomy will resolve this particular conflict. You may also have ulnar-sided pain because of a malunion, especially in the pediatric age group. And once the growth has been completed, the malunited radius will cause DRUJ instability. There is no injury to the ligaments per se, but the malunion causes DRUJ instability or incongruency, and that will lead to pain. So you can see in this particular patient, the TFCC is intact. And these are patients where you need to correct the deformity rather than go after the DRUJ. So this is the apex of the deformity. You would do a corrective osteotomy and correct the deformity, and thereby resolving the conflict or ulnar-sided wrist pain. And this was first identified and talked about by Bill Bowers, and then there were several publications about this aspect in subsequent years. Another cause of ulnar-sided wrist pain as you go on the volar aspect is the pisotriquetral joint. In the absence of trauma in an elderly patient, you should always entertain the diagnosis of pisotriquetral arthritis. So keep that in mind as one of the differentials for ulnar-sided wrist pain. Another cause is arthritis in the DRUJ proper due to a malunited dorsal ulnar corner fracture, and that might cause DRUJ pain, at times clicking and reduction of movements. Rare causes of ulnar-sided wrist pain involve some problems in the Guillaume's canal, more often than not a ganglion cyst that may compress the ulnar nerve and cause pain and paresthesias. We see a lot of cycling enthusiasts these days, and the angle of holding the handlebar will often result in Guillaume's canal and ulnar-sided wrist pain. One more very common cause that we should not forget is fractures of the hook of the hamate. These may be occult initially, but can cause ulnar-sided wrist pain. Tendinitis, either that of the extensor carpi ulnaris or the flexor carpi ulnaris, again, are causes that we need to entertain as differentials in patients who present with ulnar-sided wrist pain. So to summarize, how does this classification help me in treating my patients, whether the patient has only pain, pain with instability, or pain with arthrosis? So let us look at these scenarios. So when we have patients presenting only with pain, we always begin with a non-operative conservative line of management that may involve modification of activities, NSAIDs, splints, local steroids at times, and taping for that matter. If they do not respond to this line of management, we offer surgical treatment in the form of arthroscopy. If there is a central tear of the TFCC, you debride it to a stable rim. If there is a peripheral tear of the TFCC, you would do a capsular ligamentous repair. If there is a joint instability that is present, usually non-operative treatment will fail and you will have to offer some kind of an operative intervention. In the absence of arthritis and a gross chronic DRUJ instability, you may opt for an arthroscopic reinsertion of the TFCC if you're trained to do so using suture anchors or knotless anchors. This is the standard arthroscopy setup where we mark the portals. I won't belabor too much on this particular slide because a lot of people might be well versed with this. Very quickly, just to show you how we go in, we identify the tear, we shave the tear, and then you bring in your sutures, absorbable or braided non-absorbable, to perform a horizontal mattress suture repair of the TFCC, just like so. This is for peripheral tears. If you have a complete disinsertion of the TFCC from the base of the fovea, what we do is called as arthroscopy assisted reinsertion or reattachment of the TFCC, which is usually accomplished by these suture anchors, pretty much like a rotator cuff tear. So if you were to imagine that this is the shoulder joint, this is the bursal surface and this is the articular surface, and the TFCC, which is akin to the cuff, is brought back and reinserted onto the ulna using suture anchors. And this is an example of a transosseous foveal reinsertion of the TFCC that we saw a little while ago before we started this discussion. Now, if you have pain with instability, which is chronic, and the tissue is not robust enough, the TFCC is not repairable, you do a tenodesis procedure or a reconstruction procedure using a free tendon graft. You make these tunnels in the radius and the ulna, and you weave the tendon graft through these tunnels to stabilize the distal radioulnar joint. And the typical procedure or the classic procedure that we use is the Adamberger procedure. You can look at this gross instability, and it is pretty pronounced and pretty scary. As you can see in this, but there's an ulnocarpal sag as well as a DRUJ instability, and we need to take care of that. So this video will help you understand the procedure. We make an inverted hockey-shaped insertion on the distal radioulnar joint. We proceed with our dissection between the 5th and the 6th extensor compartments. We do a neurectomy of the posterior interosseous nerve. The 5th extensor compartment is exteriorized, and then the dissection progresses to the dorsal aspect of the distal radioulnar joint. An inverted L-shaped capsulotomy is performed to expose the distal radioulnar joint. Once this is done, we make these tunnels in the radius and the ulna. This tunnel is 5 millimeters proximal to the distal articular surface, 5 millimeters proximal to the sigmoid notch, so as to not violate these joints. So this tunnel goes from dorsal to volar. This goes in an oblique manner in the ulna to receive the tendon graft. So this is done using guide wire and cannulated cancellous screws, cannulated cancellous drill bit, 4 mm drill bit. Your graft is tunneled through these tunnels, and a repair is performed and reinforced with a double breasting of the dorsal soft tissue, thereby restoring stability of the DRUJ. So this is the same patient who had that pronounced instability to begin with, and you can see that post-operatively the stability of the DRUJ has been restored. So this is a brief algorithm that has been described in literature for acute DRUJ instability and chronic DRUJ instability. I won't belabor too much on this, we already talked about it. So in the absence of arthritic changes, usually a soft tissue stabilization procedure is performed. If arthritic changes are present, you would go in for a salvage procedure. If the instability and the pain is because of a bony malunion or a bony mismatch, you would undertake a corrective osteotomy. So the last cohort of patients is those who have arthritis that is present. Again, we would embark on treatment with a conservative line of management. And if that fails, you would offer a surgical intervention in the form of salvage procedures such as the Deras procedure, the stabilized Deras such as the Bream Jupiter procedure, or the Huey-Lynchite procedure. You can do a Bowers procedure, Sauvage-Capondry, Hemi replacement, and the Shecker total replacement. In our part of the world, both these options are not yet available, but in the Western world and in other parts of the world, this is a viable option. So again, to reiterate, if the DRUJ is stable and there is ulnar-sided pain, normal imaging, you would begin with a non-operative treatment and perhaps offer a debridement surgery if need be. If there is pain with instability, the DRUJ is grossly unstable. Identify what the reason for the instability is, and then you would do a stabilization surgery. If there is arthritis and pain with loading, non-operative treatment has failed, you would then perhaps offer some kind of a salvage procedure. So with that, I thank you so much for your attention. This is a very vast topic, and unfortunately, a limited amount of time is not enough to do justice, but I'm sure that our expert panel will help identify and discuss anything that I might have missed in this talk. So thank you very much. I'm happy to take any questions that you may have.
Thank you very much for covering this topic wonderfully. I know as a general orthopedic surgeon, I've been missing so many things. I've learned so many things today. Thank you for that. I have a question. You said that while doing distal radius plating, you want us to refix the pronator quadratus because it also acts as a stabilizer. But many a time we also release the brachioradialis. What about the brachioradialis?
Good question. So there are 2-3 concepts before I answer that particular question, sir. So there's a very beautiful paper that was published by Mark Ross, and what he talks about is restoring after you. So we assess DRUJ stability only after we have fixed the distal radius and restored all parameters. And if the DRUJ is still unstable, perhaps the reason is a distal oblique band. So you should avoid medialization of the distal fragment of the radius and try to make the distal oblique band taut again to restore stability. The brachioradialis, when you release it, it really does not retract any further because of the extensive attachment that it has to the radius. So it pretty much falls back maybe a few millimeters, maximum a centimeter from its actual origin, and will scar down again. So there is no such reason why you should repair it or suture it back again. It pretty much scars down to a few millimeters to a centimeter proximal to its actual origin, and it will not result in any functional deficit as such.
Thank you. I leave it to all the experts to discuss and bring out the best. Yeah.
Thank you.
Yes, Professor Anil.
Thanks, Abhijeet, for that exhaustive and very nice talk, as usual.
Thank you.
The analytical, what you showed, the slides was beautiful. I think for general orthopedic surgeons, one of the common things probably would have come even in the chat box would be distal radius fractures associated with ulnar styloid fractures. I think a lot of people would ask you, what do we do when there's an ulnar styloid fracture, right? And basal fracture, displaced fracture, when to fix, when not to fix, what's the relationship with the TFCC and the instability itself. I think that's one thing probably you can elaborate for the most orthopedic surgeons, because the distal radius is one thing which everybody would do, and then they would always see the ulnar styloid along with that.
Right. Does anyone from the expert panel want to address that question? Or
you're the expert today, so you have
I'm the speaker, not the expert. So, but let me just very quickly bring out 2 or 3 points, and then Praveen and Anil, Pankaj, and you can add to this. So, I think there is enough evidence and compelling evidence out there that not all ulnar styloid fractures need to be fixed after you have fixed the distal radius appropriately. Now, my take on this is in a very simplistic manner. After I have restored the distal radius anatomy or fixed the fracture, I like to assess the DRUJ stability in pronation, mid-prone, and supination. Now, this may or may not be associated with an ulnar styloid fracture. Or if it is present, I mean, if an ulnar styloid fracture is present, whether it is type 1 or type 2, irrespective of that, and we are taking into account, or we are assuming that the radius has been restored to all its angles and inclinations, and length has been restored, and now we are assessing the DRUJ stability. Now, if the DRUJ is unstable in pronation or in mid-prone but stable in supination, I would perhaps just immobilize in an above elbow splint or an above elbow cast for about 6 weeks, and then mobilize gradually. And more often than not, the stability is restored. If the DRUJ is unstable even in supination, that is to say there is a multi-directional instability, and that's something that needs to be addressed, then I would address the instability with whatever is available at that particular moment. For example, if an arthroscopy setup is available, I would do an arthroscopic repair of the TFCC or a foveal reinsertion of the TFCC for that matter. If it is a large chunk of the styloid, I would think of fixing it along with the attached TFCT, pretty much like you would fix the rotator cuff along with attached tuberosity fragments. Or I may not care about a small fragment of the TFCC and repair the a small fragment of the styloid and repair the TFCC rather than thinking much about the styloid fracture. So it is the soft tissue integrity that has to be restored in order to stabilize the DRUJ, and that's my take on ulnar styloid fractures. But this is a very, very small cohort of patients. Again, I reiterate that there is enough evidence to say that not all ulnar styloid fractures need to be fixed or addressed. And if a DRUJ instability is present, and if it is a multi-directional global instability, then you would resort to this. And the fixation may be with K-wires, tension band wiring, a headless compression screw, or a small fragment screw, whatever is available. So that's my take. I hope that helps.
Yeah, I mean,
looking at the X-ray, is it possible to decide which styloid process, ulnar styloid process fracture requires to be fixed?
Is that in the presence of a distal radius fracture?
Yeah, correct. Yeah.
I would not encourage that. I think you should take that call only after fixing the distal radius, and then decide, because a seemingly bad, displaced kind of a ulnar styloid fracture, which is really, there's a large gap, and you've done a good fixation of the distal radius, might fall back in place and may not look as bad post fixation of the distal radius.
Okay. If we are fixing the ulnar styloid for whatever the reason, can it be done closely by percutaneous K-wire fixation, or it has to be open always?
I have never been able to get my wire in a closed manner. So I have never found the styloid process, unfortunately.
Because we see a lot of ulnar styloid being fixed in closed K-wires, and that's why I'm asking this question.
Absolutely. I'm glad you brought that question out, and I would like to hear from
I have done that also. I have done also. I don't say that. But people say that it should not be done. That's why I'm telling.
Yeah, I think what Abhijeet, the point he made, the couple of points is very, very apt. The first priority is to fix the distal radius in all its glory in terms of its angles and everything. And as he said, the ulnar styloid might fall back. So pre-operatively deciding about whether to fix or not need not be the actual one which happens intra-op. It's always an intra-op decision to check for the instability clinically and then take a decision. And as again Abhijeet said, always open it and look at the styloid and fix it back. The other structure probably again on an ulnar side, which is important, is the dorsal sensory branch of the ulnar nerve. And two scenarios. One is here when we try to fix this ulnar styloid. Second is the reverse Bennett's fracture, the fifth metacarpal base fracture. Two areas where you have to be very careful. So all the more that it has to be opened, it's an avulsion kind of fracture. So you have to hold the fragment and pin it down under vision. I think that's very important, and not go by the closed percutaneous kind of an adventure there.
Since the ulnar styloid profile keeps changing with every rotation views, it is tough to fix it percutaneous.
Correct.
Pankaj?
Yeah, I would never put percutaneous fixation for ulnar styloid. It has to be a very aggressive under full vision reduction. My take on ulnar styloid might be a little more aggressive than my all three friends here. I do not believe ulnar styloid injury is an injury in isolation, or it is not an injury which is in association with the distal radius. It is very much a part of that one single entity: distal radius, TFCC, and ulnar styloid. So many times the ulnar styloid may play a role in stabilizing the dorso-ulnar and the palmar ulnar fragments of the distal radius, because they are attached to the distal radio-ulnar joint. Now, this is going into really into nitty-gritties of the distal radius fracture. Having said that, I feel we, just like anywhere else, say whenever we are in doubt about an injury, say for example a scaphoid fracture, we have been taught, if you suspect a fracture, if there is a tenderness in the scaphoid fossa, you put in a plaster, go back after 2 weeks, check. And many of these tenderness would disappear if there is no fracture. It means there was a soft tissue injury which is healed. I feel a similar approach needs to be taken for the ulnar sided injuries as well. Because we get too overwhelmed by fixation of the radius and the X-ray looks very good, we forget that there is an ulnar complex which, if not broken in a bony fashion, has suffered a soft tissue injury. And it is always these untreated injuries which eventually become painful later on, which we diagnose with an MRI and arthroscopy and decide. So if we aggressively immobilize these injuries, even if we do not go into the specifics of treating these and identifying these in an acute setting, if we simply immobilize injuries which are unidentifiable in an acute setting, a whole lot of patients who otherwise suffer from ulnar-sided wrist pain after a wrist injury would do much, much, much better. Frankly speaking, almost all the causes that Abhijeet enumerated, almost none of them are diagnosed in acute setting, except for ulnar styloid fracture. And even for that ulnar styloid fracture, which is very easily diagnosed in an acute setting, we are very uncertain about whether to fix it or not. So we are much better off immobilizing these risks wherever we are in a doubt, rather than mobilize them looking at only at the radius and then have a few patients coming back with ulnar sided disc pains. Or even in absence of a distal radius fractures, aggressive cast immobilization of these patients, similar to what we do for suspected fractures of the scaphoid, will prevent a lot of patients going in for arthroscopic surgeries later, or going in for relentless pain later on.
Precisely, Pankaj. That's why I brought this issue into a picture when a lot of people who do distal radius are probably watching this. So, see, we are taking away pronator quadratus, and we might suture, we might not suture, depending on the status of the pronator. A lot of times, so badly lacerated, we might not be able to suture. We can't see the intraosseous membrane bundle, which Abhijeet showed, the oblique bundle. We don't know what's happened to the ECU subsheath. And we are seeing an ulnar styloid fracture, which might be associated or might not be associated with the TFCC kind of an injury. So as you said, I think that first 3 weeks of time for soft tissue healing should be very, very crucial. When people tell I would mobilize them second day, or I mean, it need not be so aggressive a lot of times. You can still immobilize them in an above plaster for three weeks and then start mobilizing them. I think a lot of people will do really good in that sense, for the soft tissues to heal whatever is torn and things will settle down with that 3 weeks of immobilization.
That was a good point which Pankaj brought out. I think many of our senior professors, they would say, I never used to have this ulnar side wrist pain, and you all are talking so much ulnar side wrist pain. But I think the difference is because with all the good implants, if you start mobilizing very early, then they are prone to get that ulnar side wrist pain, which previously also would have happened, but because of immobilization, we got through. So whenever there is even mildest of doubt, immobilization is a good thing. And when this
And
point has come, what should be the position of immobilization? Dr. Abhijeet.
Before Abhijeet, Abhijeet, before you answer that position of immobilization, Praveen, nothing wrong in mobilizing them early if you have identified and aggressively addressed the soft tissue injury part as well.
Yeah. So if there is mildest
Now,
doubt, you immobilize.
yes. So if that is not possible, even for the most accomplished wrist surgeon, it may not always be possible to do that. In that case, we are much safer to immobilize them.
That is a good point to come out of this discussion.
So, in terms of immobilization, now we all know that a very large percentage of patients who have distal radius fractures will also have some kind of a ligament injury. Now, if the scapholunate ligament is not injured or you haven't repaired the scapholunate ligament, I would usually like to immobilize for a TFCC in a position which is just short of supination but not full supination. If there is a scapholunate and a coexisting TFCC injury, and I had this talk with Maria Esplugias, I believe her name is, in the IFSSH meeting. So when you supinate, the carpus will subluxate when there is a scapholunate injury. So if you're repaired, it's always best to immobilize in a mid-prone position. And in the absence of a scapholunate, I think something which is just short of full supination and the patient is comfortable. Full supination can be very painful and very discomfort kind of generating kind of a position. So that's how in an above elbow, either a Munster or a sugar tongue cast or a splint. In a cooperative patient, if the patient is not cooperative, I would put in a proper above elbow cast or a splint.
Shall I take it as a mid-prone position, above elbow slab or above elbow cast?
A little bit more than mid-prone, so just short of supination.
Yeah, because even if you take it more than that, again the gravity will act on the carpus. Because in the mid-prone, is the maximum compression forces are working, you said.
Correct. And it stabilizes. It's a position of maximum capacitance, as we call it. So maximum stability and capacitance.
Yes. Praveen, you have to unmute.
I would probably take the decision intra as I'm checking the amount of reduction and how stable it is in which particular position. It could be just in neutral, it could be midway between supination and neutral, or it could be very rarely, it could be completely neutral, supination. So on table, when we check and then see how nicely the ulna is getting seated onto the notch, I think probably that would be the decision making as to which angle it should be immobilized. And we're keeping it up probably at just about 3 weeks and then start making it below elbow and start mobilizing with the splint. So I don't think we should have too much concern with the amount of stiffness there. Yes.
Right.
Other important thing is not to let it be in pronation. Because if it is kept in pronation, if it is a below elbow, patient kept in pronation, very difficult to get a supination then. And even if there was some DRUJ injury, the dorsal subluxation of ulna would become so difficult to reduce. So anything beyond mid-prone towards supination to avoid extreme supination.
I remember SRS telling, always the hand should be facing the patient.
Yeah, palm should be just like looking.
Very rarely you would do this for any kind of a situation. So I always tell my residents the same thing.
Babas. All Swamijis will do that.
Hand should face the
palm facing the face.
Yes.
Yeah, but palm facing the face is fine when
not in this generally.
Generally.
Yeah, I completely agree. It is there was a time when I always thought supination was the best position for DRUJ, but invariably most DRUJ would be stable in in full supination, especially when we were treating the most complex fracture that we would treat around the wrist was the Galeazzi. And we had not delved very deep into the wrist at that time, 15,
Yeah.
16 years ago. And wrist was always immobilized in supination. However, as we are repairing more and more soft tissues on the ulnar side, my preferred position has been mid prone. If your DRUJ is not remaining stable in mid prone, then there is some issue with the soft tissue balance. Perhaps something which needs to be repaired has not been repaired. Uh, uh, so mid prone is the position that we should be looking at.
Abhijeet, you showed a ring with weight so that the person can rotate it. Is it available, or you have got it done locally made, or what is the weight you have to test and how to test and where the pain comes? Can you tell little more details of that?
Well, it is just to show the biomechanics. It's not something that is available. I took it out of a publication, but we just use dumbbells for our PA view or the load-bearing view to see for any convergence or a radio-ulnar convergence kind of a thing. But other than that, we use a Jamar dynamometer for the grip strength, and that's about it. This is something, it's a contraption that can be made anywhere. A local fabricator can get it made.
Yeah, that's correct.
In fact, Abhijeet, if you remember, I think both of us had seen it in Malaysia.
Yes.
Jamar has a dynamometer specially made for the forearm rotations.
Yes.
Where you can check the strength of supination and strength of pronation.
Yes. It's available with this company called Arex, I believe, this particular instrument.
Yes, Anil.
Probably one other area, probably again related to general orthopedic practice, would be radial head excisions. Of course, now a lot of people would replace it, but there is a component where radial head excision is done, and then it has a effect on the distal radial joint with an ulnar impaction. I think that's another thing probably you can elaborate as to not to, go for just a radial head excision and, so think it as a single joint as you showed as a parallelogram there. And so there is an effect of one getting damaged because of the other. Right?
Sure. So I think radial head excision, if you talk of radial head fractures, so there is not only an aspect of the distal radioulnar joint, but also the elbow joint for that matter. So if the medial hinge is intact, that is when you would think of maybe excising or replacing a non-repairable radial head fracture. There is this documented evidence that in some patients there is a proximal migration of the radius when the radial head is excised, and this may be because of a missed injury to the interosseous membrane in such patients. So essentially an SX low-pressity kind of a injury, and that would lead to pain in the distal radioulnar joint. And a chronic SX low-pressity injury, there is really no good solution to this. So it is very important perhaps to keep this differential in mind and deal with it appropriately at the first chance that you have. So if you feel that there is an SX low-pressity kind of thing and the radial head is not repairable, you cannot fix the entire radial head in anatomical congruity, I think it's best to replace it. Now, the options that we have for replacement are not great. And the biggest problem of replacing the radial head in a traumatic situation is either understuffing or overstuffing, both of which can be problems. If you overstuff, you can cause capitulum chondromalacia, and then that's a different problem you're creating. If you're understuffing or if the radial head prosthesis is not of the correct height, there is another problem of an instability pattern that may be created. So radial head prosthesis replacement should not be taken lightly. It's not just getting a block and putting it in there. You have to take into consideration a lot of things, including medial hinge or the integrity of the medial collateral ligament of the elbow. A lot of patients with such severe injuries of the radial head also have an injury to the lateral ulnar collateral ligament, so that has to be repaired. along with your replacement. So something that we should bear in mind.
With just radial and isolated fractures, if I am doing excision, think that there is a no interosseous membrane injury. By chance, on table, I see that the ulna is moving up, a radius is moving up, and the ulna is going down. Is it possible to fix with a K-wire distal radio ulnar joint in supination and expect the healing of the soft tissue to happen and keep it in slab for about 4 or 5 weeks?
I'm not sure if we can really see the proximal migration of the radius that effectively in an acute situation, and it is not reliable indicator of what may happen next. But I would not put K wires across any for stability. I would rather restore stability by ligament repairs, by immobilization, rather than put K wires across, because one of the biggest risks of putting in a K wire across the radius and the ulna is an injury to the posterior interosseous nerve. So I would really not advise
Yes,
such a
because we have done so for so many years radial head excision. How many patients have come back with pain?
sure.
That has to be. I think Professor Anil will talk more about that. Sir, have you seen many patients coming with wrist pain because of the radial head excision?
Uh, as Abhijeet said, it's not in an acute setting, sir. It's always a chronic migration which happens. And then the mismatch happens where you see the ulnar impaction kind of a presentation. They would not come with any problem near the elbow. Actually, they come with the problem at the wrist when you start seeing ulnar impaction. And it might take many years. So probably that's why we don't see them, as we don't really follow these patients for such a long time. So we don't know when they would come back. And when I looked at the literature last time for something else, there are hardly any studies, any follow-ups. There are only case reports talking about, there are only 4 or 5 case reports actually. We had a seminar and we found out talking about this kind of problem, and patient has come after many years. So we don't really know at what point of time your own patient might have gone somewhere else for some other problem as to the wrist pain or something like that. But definitely, we don't know the natural history, the timeline of when they could, that proximal migration happens. So we were always taught as postgraduates, don't exercise the radial head, isolated radial head fracture. And one of the common reasons would be proximal migration. Or don't exercise it in children because again, it's a proximal migration. But nobody has told us when it will happen. So there's no answer for that.
Okay. Yes. Yes, Praveen, any questions?
Yes,
Yeah.
so I think it will be nice if Abhijeet could bring out 2 very common points which every time people have confusion about. So what is the role of local steroid injections for this ulnar side wrist pain? So that is the first one. Second one, when you are assessing for instability, we know the instability is the indication for doing surgery most of the time. And the test, especially the ballotment, is quite subjective. So do you have any tricks for a person who is not a proper wrist surgeon to really know that it is unstable, or you can continue with immobilization or conservative?
Thank you, Praveen, for those questions. So, as far as the local steroids go, my threshold for giving a local steroid is extremely high. And in the rare occasion I would resort to a steroid injection, I would give only once, with a clear understanding that we are treating the pain, not the root cause of the pain. So steroid is a very potent, locally acting anti-inflammatory kind of an agent with, there's only so much that it can do in terms of pain relief. So the first thing that we should do is not promise the patient that this is going to be a definitive cure. This is going to be a temporary stopgap kind of a management protocol. And it is very important to be very careful about where you're giving the injection. So you should avoid giving it directly in tendons for that matter. There is a very high risk of rupture of the tendon if it is given intra substance. So using fluoroscopy to be sure about the placement of your needle is a good way to give the steroid. But like I said, in my personal practice, I have a very high threshold for injecting steroids, and I would reserve it for patients with inflammatory arthritis more than patients who have traumatic pain. As far as the ballotment test is concerned, we usually do it with the patient seated on our right hand side. We make the patient comfortable, relax the shoulder and the elbow. The elbow is pivoted on the table, and we examine the DRUJ instability in 3 rotations: pronation, mid-prone, and supination, and we compare it with the opposite side. In doing the ballotment, I do it 2 ways. One is where I stabilize the radiocarpal axis and ballot the ulna, and the second time I stabilize the ulna and ballot the radiocarpal axis around the ulna, and then I repeat it with the other side. Now this is coupled with the load bearing and the compression and the lift off test, the hypersupination test, and if all of these are significant or if the patient experiences pain, then we would start thinking about some kind of a ligament injury. So I hope that helps. Anil and Pankaj, do you have anything to add to that? And Praveen, yourself, do you do the same way, or is there anything?
One other thing which I observe many times is TFCC on an MRI is a very common finding. So whenever a patient coming with a TFCC tear, MRI report of TFCC tear, I think we have to first keep the MRI on side and make
True.
sure that this is the reason for the pain. In
Very
fact, just yesterday we had a patient who is come with MRI report and he has come for a viscoscopy and TFCC repair. But on detailed examination, you see he's got all hypothinner wasting, thinner wasting, and finally he came out to be a case of neuropathy. So one
Yes.
thing very careful to, because MRIs most of the times would show some injury. So we should not just go for MRI, and clinical examination as detailed by Abhijeet is the
Absolutely.
main important.
No, it's not me. It's what I've learned from Anil and Pankaj. I think clinical examination is of paramount importance, and this is something we have to keep telling our residents and fellows. We are in such a hurry to, just look at the investigations that the patient has brought along, and then do a reverse engineering kind of a thing, and then come to the diagnosis. I think that's a very wrong way. I've always maintained that investigations should not be a eureka moment for you. Investigation should only supplement what you already know from a clinical examination and the history. So meticulous examination is of paramount importance. That cannot be overemphasized. Yes, Pankaj. You need to unmute. Unmute, please.
In fact, the point that Praveen brought up, I actually had noted down here. The reason that we see a lot of MRIs reported with TFCC tear is because now radiologists are becoming familiar with their diagnosis. There was a time 10 years ago, nobody was diagnosing TFCC tears even on MRI. Now, a lot of radiologists are diagnosing. And therefore, everything on the ulnar side does get labeled as TFCC tear. It's almost like a confirmation bias that is happening from the radiologist. So until we are able to correlate clinically, or until we are able to confirm these findings on a wrist arthroscopy, we should not jump on the MRI diagnosis. That's for sure. That's for sure. Otherwise, second point about the steroid and the inflammatory pathologies that Abhijeet was talking about. One, the instability requires provocative maneuvers for diagnosis, and these provocative maneuvers will unmask the instability, may not necessarily produce pain unless there is an underlying degeneration or underlying synovitis. So this is my understanding of these maneuvers, and whenever there is an synovitis or degeneration, that part will respond to steroids.
Even in for I feel whenever we have got instability, there is not much role of steroids. But if
Yes,
clinically instability is not there, then ulnar side wrist pains, for them steroids work quite okay.
absolutely. And even in presence of for example, I very strongly believe that when the DRUJ is unstable, the distal ulna is unstable, that is one of the commonest causes for ECU tendinitis. The unstable ulna itself causes, because unlike all other extensor tendons, ECU is the only tendon which is stable with respect to the bone on which it is lying. Rest all extensor tendons are, they move with the extensor retinaculum. The ECU does not have that freedom. It must stay with the ulna, which is now rocking out of its position, and that part of pain will respond very well to steroid. Unfortunately, the diagnosis that everybody might cling on to is the ECU tendinitis and not focus on the instability underneath. So these are the two different components that we may have to treat.
Yeah, because there are enough asymptomatic people with subluxation of the ECU, in the sense that it is not correlating that they should have tendinitis. So it is a normal phenomenon for the ECU to move around in supination and in pronation, and the axis changes. And because it's got its own subsheet, it has that mobility to move around in that. So that also is the other thing. But as you said, probably one typical indication for a steroid would be a good, properly diagnosed ECU tendinitis. And the other thing, what you asked was the translation. I think that's what you asked, allotment. Could you? So
Yeah,
one of the reference we have got, we had a DRUJ study was like how we do a drawers, and then you see how much it moves. So if it is less than 50%, up to 50 and beyond 50, when you move this. So that is one of the grading we got with a reference after searching for a long time in terms of this. So you would do in all positions, but the translation between the head of the ulna and the sigmoid notch is that less than 50, 50 and more than 50. So that is one of the grading which has been in the literature. I'll send you the reference for that. So that is one way of looking at the grading of instability. And the position, as Abhijeet said, in which position it is unstable. So that two things you need to add up together.
I think again, like I said, a seemingly innocuous instability in the clinical setting uh, would be a drastic instability under anesthesia, and that's mostly because of the muscle guarding, and the muscles that are active. So that's something that we need to take into account.
And then the generalized ligament laxity, which needs to be recorded preoperatively for the patient.
Abhijeet,
Sorry.
sorry.
Sorry,
I think
go
you
ahead.
presented one case of a child developing a DRUJ instability because of malunion. Actually, just yesterday itself, one of my friend called and he told he has got such case, and then immediately he put this. Okay, there is a webinar coming up, so so you again
Yes,
elaborate on
yeah.
that case. I think he'll be very happy and waiting for your
Certainly.
answer.
So we are seeing a lot of these such patients because I have a few good pediatric orthopedic colleagues, and especially when these patients are being, so there's something called as a Mubarak's line that we all know of, the ulna and the radius. So if there is any malunion from a diaphyseal fracture that results in an angular deformity or a rotational deformity, uh, it is usually the patients usually present with some DRUJ problem, and it is extremely important to identify. So you need to have a good X-ray having the elbow, the forearm, and the wrist. You need to have an opposite side X-ray. I'm sure that you must have heard Jeff Ecker speak of doing this corrective osteotomy using 3D printing and all that. And I think in adults, it's more so with the distal radius, but in children in the growing age, when they have a fracture of the diaphyseal aspect and then the bone grows, they have a late presenting DRUJ instability, and it can be very debilitating, especially because children play. They are into gymnastics for that matter, throwing activities, writing for a long time, and this can be very painful and debilitating for a lot of people. So you have to identify the small cohort of patients where the instability is a result of the malunion, correct the malunion. Now, there is another caveat to this. There are so few patients who, despite correcting the malunion, may not still have DRUJ instability, and that is because of a soft tissue problem at a DRUJ. So just like we do a distal radius fixation and test for stability, you do a correction of the malunion and test for stability. And yet, if the DRUJ is unstable, you have to resort to a tendon reconstruction procedure in this. However, the placement of the tunnels is just at the area where the epiphysis is. So make sure that the epiphysis is closed and then you do this surgery.
On the diaphyseal fracture, actually most of the time the DRUJ may be okay. It is only the bone which is plucking
Correct.
out, especially if they
Correct.
have ligament laxity. They
Correct.
would come with cluck with each rotation. So we need to correct the malunion rather than going to the
Correct. So the only thing is that because of the chronic subluxation, the capsule may get stretched out, and that may cause some instability despite your correction at the malunion site. Pankaj, you were saying something, right?
Yeah, my question was slightly off track. It was about the DRUG replacement. Not, we were not speaking of radius head replacements for many years, and when I was studying and training, we almost never did a radial head replacement. It was always excision. It was not even fixation. And now we are talking about radial head replacement and its role in allowing the medial side of the elbow to heal. And now we are talking about DRUJ and impingement between the ulnar stump and the radius. Now, do you think a procedure which has withstood 100 years of scrutiny uh, would get replaced by DRUJ replacement as a primary solution for DRUJ arthritis, or should it still be a secondary solution for a small group of patients who might have impaction of the ulna onto the radius?
Great thought. And let me break that question down. So let us talk about a group of patients where the demands are different from the young active individual who has had some kind of a DRUJ problem and has had a resection. And this is exactly what Louis Shaker talks about. So in the case where he or she is an elderly patient, inflammatory arthritis, and the requirements are really not all that much, you can do a salvage procedure, stabilize Diracs, Bowers, Sovic-Apongi, whatever, and they usually would do well. It is a young active individual, and wherever you resect the ulna, there is always ulnocarpal, radio-ulnar convergence, and that can be very debilitating. And the more you resect, the more severe it gets, and and I think the most drastic solution for this is a one bone forearm. Now, Louis Shaker, I was very privileged to have trained with him, especially when he was developing the aptus prosthesis. And he has come up with a very ingenious similar process even for the radial head. So in all these chronic cases, it's a very, I think, an ingenious and a very fantastic concept. So just like you fix the plate on the radius and you have a head in the ulna, here you have the radial head and the plate is fixed on the ulna. And I think it's a recent development, and I think you can check online at the Aptis website to see it. But I think in desperate situations where really there is no good solution, uh, in today's scenario, perhaps this is the best solution. And that stabilizes the DRUJ. All those concepts of biomechanics that we talked about are restored, and prehension and your hand function is improved. So yes, it is it's a completely different ball game as compared to other compressive joints such as the hip, knee, and ankle. I think the frontier in replacement arthroplasty today is the elbow and the wrist joint, and of course the MCP joints perhaps. So maybe in the near future we will have better outcomes. Yes, Anil.
Yes, Dr. Anil.
In terms of the replacement, I think the longest follow-ups have been, I think, an average of about 10 to 11 years now. And one of the things is basically the ulnar head instability, the soft tissue instability, because it's really difficult to create back the entire TFCC construct with its, interosseous membrane and everything coming back to where it were. So I think most studies talk about the ulnar head soft tissue instability. And in fact, I think Sanj Kakkar has devised a procedure called calamari procedure, where they use a allograft of meniscus and make it as a labrum around the ulnar head. So an ulnar, I mean, the labrum kind of a construct is made around the sigmoid notch with a meniscus, allograft meniscus actually. And I think that is one of the most difficult technical point or part where replacement is failing. And most long-term, the long-term has been only, I think, 10, 11 years or 11, 12 years probably. I think that is the only one which is holding back people to replace it more frequently. Otherwise, I think, as Abhijeet said, probably it's the next thing you need to think of, at least in the Indian scenario.
Yeah. I think the precursor for the calamari procedure was the procedure of Soterianos, Dean Soterianos, where he used an Achilles allograft as a cap for the distal ulna. And then you're overstuffing the joint, and it's like a soft tissue interposition, if you will. So whether you're doing it in the sigmoid notch, whether you're putting on a cap onto the ulna, the principle or the goal is perhaps the same. And like I said, I think we are yet far from a feasible, viable kind of an option. But I think we are inching closer with all these great geniuses at work. I'm sure we will find a solution very soon.
Okay. Any last question?
What do you think of directs, Abhijeet?
Yes.
I've always the procedure is great, no doubt about it. What you use the procedure for is important. I think it's not the procedure, but the surgeon and his indication, his choice of indication, that makes the ultimate difference. And of course, executing the procedure. So it's not only the philosophy, it's not only the technique and the skills, the indications. I think they are all responsible for the outcome. Now, elderly patient, 80 years of age, maloriented distal radius with loss of pronation, supination because of an ulna that is positive now, non-dominant hand, I would not hesitate to do a Darras procedure. But yes, I would still like to stabilize the proximal stump. But I would not perhaps do an inflammatory arthritis, rheumatoid arthritis. Darras works perfectly fine, I guess. As long as you're not resecting it too much, as long as you're respecting all the soft tissue closures, repairs, I think it works fine. And then you have to talk to your patient and counsel them about the fact that what God had given, we are taking away, and it's never going to be, there may be problems down the line. But it does provide a very robust, feasible solution, at least in the short to the midterm. So yes, the procedure has stood the test of time. There are hundreds and thousands of people who are doing it. So the procedure is not to blame. I think if at all there is a problem with the procedure, it is a surgeon and his indication for utilizing that procedure that is to blame. And with all due respect and with all humility, I'm saying this.
Whichever ulna is very stable, that is not a good case to do a Darras. Yeah. Because instability will only keep going up and it is going to cause problems in the future.
Yeah, I mean that's the message. Probably again, everybody should take that. Abhijeet specifically mentioned above 80 and all those kind of caveats there. But when we see patients with 40 or 50 and everybody coming with a Darras, it really is not a good thing. No. So that's the message even I wanted to convey, that there are so many other procedures which can be done. And I think the indication in that sense could be again broken down into the ulnocarpal and radioulnar. So which area is damaged? So if you have an ulnocarpal area which is completely damaged, ulnar head fracture or any of those things, and that is where probably a Darras would be the option. But when you have a DRUJ, the sigmoid notch area with ulnar head articulation damaged, I think Darras is not the answer. It should be a Kapanji's procedure. So that kind of a differentiation should also be probably done sometimes for you to check clearly which area is arthritic, because the ulnar head participates in two joints. And so that also should be very clearly marked out which articular surface is damaged. Is it the one towards the carpus or is it one towards the distal radioulnar joint? I think that also is very, very important. Proximal stump stabilization is a very important step even in Darras, like the way we do it in Kapanji, so that the radioulnar convergence is reduced. I think all these things should be taken into consideration for a Darras. Pankaj.
Anil, the debate about Dara and Sovaikapanji will continue. I confess, I've never done a Sovaikapanji. I've been doing Dara for independently for almost 20 years now. I've done it for age groups ranging from 20 to maybe 85, 86. Typically in private practice, when we do a procedure and it has an ongoing problem, say if a problem develops after a year, 2 years, 3 years, 4 years, patients do go back and say, okay, this is happening. I want to ask all the panelists, how many of your Dara patients, irrespective of their age at which the surgery was done, are following up with you long term for that procedure? I will answer first. None of my patients so far are they following. They're perhaps following up with Abhijeet, but none. I mean, they do follow up for first 2-3 months, and I think most of them have not followed up for longer than 3 months.
Maybe you are chosen for correct indication.
Yeah, exactly. Exactly. I would like to share with you all a wonderful lesson that Pankaj taught me a long time ago. And he recounted what Nicholas Barton had, I believe it was Nicholas Barton who had said this, that if there is a procedure or technique that that is going to help your patient and you don't know it, then it is well worth the time and the effort that you should spend in learning that procedure or that skill in order to improve your patient's, well, healthcare delivery or well-being or whatever. You remember, Pankaj, you had told me that sometime.
No,
I think it was Anil.
who told you that? You're giving the wrong credit.
I think it was Anil who taught us all these things.
That was my slide in my arthroscopic assisted distal
Oh,
radius.
I am sorry about that. I have many masters, so
I know how much you hate me. I know that. No.
No.
Such professor type teachings don't come from me.
That was a wonderful.
It was in relation
to
to
arthroscopy.
arthroscopic assisted distal radius. I mean, that is because everybody would say, jump and pounce on me, telling, why are you doing this? And, how can you do this? Wasting so much of time and everything. But it's just a skill, additional skill. And that is when I put that thing. And I know you had taken a photo of that. And then it's okay. You don't give me the credit. It's okay.
Yeah, about Dara, I mean, a procedure which has stood the test of time for over a century, there has to be more to that procedure than just knocking off the bone. It's a procedure which needs to be performed extremely delicately, and it's a very precise procedure. And as we grow in our specialty, I think we are getting better with Dara procedure. And that's the reason we are able to give good results with Dara. It's not only about knocking off the bone, absolutely not.
No, it's basically shelling out that ulnar head out of all tissue cover and then putting it back. The moment you do that, it's a very stable construct.
I agree. And I must admit, in the beginning of my career, when I was not stabilizing the distal ulnar stump, which I now do in every case, just because I have to show that I'm a specialist, so I'm stabilizing the stump. But even when I was not stabilizing the stumps, maintaining a good periosteal sleeve and very diligently excavating the ulna out of the soft tissue cover did give an excellently stable distal ulnar stump without much problem.
I think just like a fracture is a breach in the bone complicated, I mean a soft tissue injury complicated by a breach in the bone, I think orthopedic surgery is essentially soft tissue surgery where you're also, kind of dealing with bones in part, I guess. So
the president, sir, won't agree with that.
I'm sure he will.
Yeah, I have to agree when 3 or 4 of you are around me.
No,
yeah. Anyway, I think we have discussed quite in detail and we are already overshot almost by 20 minutes. So that was a nice discussion. I should thank all of you. Thank you, Abhijeet, for your wonderful exposure to ulnar sided wrist pain. And the take-home message he has already given. But one thing I want to reiterate is when the patient comes to you with a lot of X-rays, MRI reports and everything, Don't start seeing the reports and then start seeing the patient to fit what Abhijeet said as reverse engineering. So fit the diagnosis into the patient. It's always any patient, not only wrist, any patient comes with a lot of investigation. It's always better to examine the patient, come to some clinical conclusion and have a provisional diagnosis, and then look for whether your provisional diagnosis correlates perfectly with the clinical investigation already the patient has got, like MRI and other things. That was a great lecture, Abhijeet. Thank you for that.
Thank you, sir.
Thank you, Professor Dr. Anil Bhatt. I know you are a very busy person. You are a deputy dean of a huge medical college, and in spite of that, you could take out your time to be just being a panelist on this today's panel. You are really carried the discussion in the right direction. Thank you very much. I would like to thank Dr. Praveen Bharadwaj from Ganga Hospital also. I know he was just out from the OT and he had to log in the last minute, and he did justice by taking the discussion in the right direction. I would like to thank Pankaj Ahire again for all the wonderful discussions we had together. And also I'd like that sometime he should share with all of us the proper way of doing direct procedure. So that's what I would like to say him. I would like to thank Dr. Neeraj Bijani and Dr. Ashok Sham from OrthoTV. Friends, before I conclude, I would like to tell that day after tomorrow on Thursday, we have One Person, One Talk series by none other than Dr. Anil Karkanis from Mumbai. He will be talking on use of Sarmiento brace in getting good outcomes. He will be covering fractures of the humerus, femur, and tibia. We have a wonderful list of panelists in the form of Dr. Arup Mukherjee from Max Delhi, Dr. Vikas Agashe from Hinduja, then Dr. PNB SP Prasad from Hyderabad and Khammam, Dr. Rajendra Chandak from Nagpur. So don't miss that opportunity to join day after tomorrow for this wonderful conservative line of treatment of the fractures. Thank you very much. See you day after tomorrow.
Okay, thank you very much, Ashok, and I welcome the panelists and our guest speaker today, Dr. Vijay Bose, who doesn't need any introduction. All of us know him very well through his pioneer work in hip arthroplasty and his approach, the posterior hip approach, which he has really innovated very well. Along with my co-convener, Dr. Surendra Patil, Ashok Ram, I would like to ask Vijay to talk to us about the posterior hip approach and his innovations which he has done and published. I must share with you that when I came back from UK in 2005, Vijay had come to Ruby Hall and he did a ASR hip, and I remember his approach, very well. It is etched in my memory, and it's a great pleasure to welcome him in this conclave where we have no pressure of time and we can really elaborately look at his posterior approach, and the panelists will definitely discuss it more. And without further ado, I would welcome Vijay to share his screen and start his talk. Thank you, Vijay.
Thanks, Kiran. First, let me express my thanks to you and Dr. Surendra Patil for inviting me. Real honor to be part of the HIP conclave. Good to see Phil and the hope that the delegates would benefit the usual Ashok Shyam. We see him every week. Okay, so I hope the delegates will utilize the time and really benefit from this very nice format that the conveners have put up for us. So with that, I will share my screen. Right, okay, here we go. Right, Okay, let me just get the view. Right. Okay. So that's the post-lateral approach. So the entire talk would be just on the approach. I won't be going into any other part of hip arthroplasty, just the approach.
Yes.
So the post-lateral approach was first described by Austin Moore in 1957. And since then, there have been, I must say, only minor modifications of that. And I think we're all familiar as orthopedic surgeons. But the key, as I expressed in my talk, is to constantly keep improving what you're doing. So it's an easy, simple, familiar. We were all taught this in our MS orthopedics days. It's internervous, and the real great thing about it is extensile. You can use it to go and fix an acetabulum, posterior column, etc. if you need that during your surgery. And another very important advantage over the other approaches is that you can convert it to an ETO in all revision arthroplasty. So it's really an extensile and a great approach. And of course, nowadays we do GANS flip as a part of exposure for complex cases. And again, it lends to itself very well for you to proceed with a GANS type procedure. Now, the first thing I want to emphasize is the how you must hold the pelvis. Now, I probably have I don't know whether it is a distinction, but probably I've done the maximum number of live hip surgeries in India. So my count has just crossed 85. Live demonstrations all over India I've done. And I must say that in spite of me operating in very reputed hospitals all over India, in many hospitals, the positioning of the patient is, they have robotics and they have navigation for you to use. That's all great on one side. But the real important thing is having good positioners when you do hip surgery. I'm sure Nikhil would agree to that. And many times I find this is wanting. We are not able to. And once you are not positioning the pelvis in THR, it's a wandering target. Truly, it's a wandering target. So you'll find that the patient just falls in a posterior approach anterior like that, and the version changes, and you have no clue as to how to compensate for when the patient falls. So usually what we do is common mistake that we all do is that we think that as a patient falls, between the supports, the patient falls like that, and you ask the anesthetist to move the table the other way. So although you correct it partially, the axis of rotation of both this is different, and therefore it's not a true correction. You do make some correction, but not a true correction. So you're always in a very difficulty to get your competent positioning. That's a common mistake that we all make. The other point I want to emphasize is getting for at least for the post approach, support on the superior ASIS. Now, most people would put it on the symphysis pubis. This is inadequate, I think, because it is a fulcrum for it to move anteriorly. When the assistant pulls, retracts anteriorly, and unless you have something to support the superior ASIS, and of course your sacral support must be very good and try and obliterate the lumbar lordosis. And this must be like a iron, clad. It's like completely no movement, micro movement at all. That I think is very critical. Now, many people have modified the post approach. These are some of the names: Dorr, Swanson, Skulko, etc. Each one has its slight variation of the approach, and many of them went down the mini incision route. And we also went briefly for that for a year and a half. Then we found it has more problems. And I must say that in 2020, all mini incisions have faded away. And all we now realize that it's not very important to limit the size of the incision, doesn't give any advantage. And this was the JBJ's editorial by Chit Ranawat, who said that mini invasive surgery seems to be a marketing tool for a lot of surgeons, and this must be avoided, and he condemned that. However, we must acknowledge that although it is a marketing tool employed by some surgeons, etc., there's no question that the mini-invasive approach brought in a phenomenal improvement in peri-operative analgesia. Absolutely, and that we have really benefited from that, and it led to the development of many innovative instrumentation. And I think during that phase, we also developed many instruments that we use to even today. That was really good. And for whatever reason, we were able to ambulate the patient very well. And I think that all is a very good thing that has happened. Yeah. So, although mini incision is not important, size of the incision is certainly not important. I advocate all juniors that you must not have a predetermined size and go in and say, I'm going to do a 6 centimeter or 7 centimeter. That's a very wrong concept. However, it's a good idea for you to keep restricting your incision as you develop experience. Now, imagine you are the patient and the surgeon cuts you 1 foot. How would you feel? So the common mistakes that the surgeons make, junior surgeons make, is that they're not analyzing what they're doing. So my tip to you would be always you measure your incision size. I'm not saying you limit it, but please measure your incision size and the BMI of the patient. And you can see whether, without compromising in any way whatsoever, can I decrease the skin incision size? And you may find that many patients are actually wasting skin incision size. Absolutely. So a key point is you always use a skin marking pencil. So you do it very diligently. And what I would like to highlight is there are 2 components to the posterior incision. Yeah? The distal part in the thigh is your acetabular component. The proximal part is your femoral component. Now, suppose if you are struggling with the acetabular component, then you must extend the distal part. And you are struggling with the femoral. You can always extend the skin incision. So you don't have to make a predetermined. Always start small. If necessary, don't hesitate to extend. And then if you find that your incision gets smaller and smaller as you go along without compromise, and I think that's a good thing. So I would constantly try to reduce the skin incision for THR with no compromise, or constantly strive to be less traumatic and continuously improve on the rapidity of recovery. And once you document the BMI of the patient, you'll know that last year you did this BMI, this size incision, this year you have been much better, although nothing else has changed. So that's a very good thing. Now, the traditional pros and cons of the post-lateral approach is that, of course, we know it's the most extensive, no question, no one can argue with that. It's useful in complex situations. It is really the go-to approach. And the gluteus medius is left intact. I'm sure Kiran would say that there is no abductor compromise, great extent in the anterolateral approach also. But let us see what he has to say. But the real thing about the post-lateral approach is that it's supposed to have a higher chance of dislocation. Okay. Now, this has been very historical. So, although there are a lot of earlier publications saying that there's a higher chance of dislocation, now we know that after we started to close the capsule very well, brought up by many authors, and the most importantly by Beverland, that the chance of dislocation goes extremely low. And I must say that he published in 2007 that I have done now just crossed 4,000 primary hip arthroplasty. And to the best of my knowledge, we have had only 2 dislocations in 4,000 primary hip arthroplasty. One was very recent, the complex hip. And the next one, the other one was a surgery that I did for another surgeon in Mumbai. And I didn't close the capsule myself. It had dislocated. And I had to go back to Mumbai to close the capsule again the same day. I went there. After that, he didn't have any dislocation. So those are 2 cases that I know, 4,000 posterior dislocation in primary THR. In revision THR, we have had many dislocations, not to be confused with that. So other important modifications would be the fair approach by Mr. Temple from Exeter. I've seen him do that. He goes between the interval between quadriceps coxae and the quadriceps femoris, as you call it. I have tried doing this, and I find that it comes in the way. And as Ranawat says, if you don't take out the short accelerators yourself, where your assistant is maneuvering the thing, the short action gets peeled off. And I would agree with Ranawat that trying to maintain the short accelerators in a posterior approach just doesn't work. So this is the modification that I described in the JBJ's British in 2010, which I called as the NCP approach, or the neck capsule preserving approach, which I'll be showing you. This I described for hip resurfacing because we believed that the neck capsule has an important role. The blood supply for arthritic hip, not a native hip, but an arthritic hip. It has got the retinacular vessels. It's got some important role, and that's why we want to preserve the capsule. And that's the genesis of this approach. But it was so good that we started using it in all our hip arthroplasties. Primary, in revision, of course, we don't do that. So showing you, I hope you're able to make out the orientation. This is the head end. This is the foot end of the patient. You can see this is the acetabular limb of the capsule I opened like a door. And this is the femoral end of the capsule. So I've incised the capsule in between. I finished the arthroplasty. You can just see the ceramic head there. And now I'm closing the capsule through 3 horizontal mattress switches. You can see that. So we close capsule to capsule. We don't attach the capsule to the trochanter, but capsule to capsule, what we opened, we'll close it up like that. And you can see how it's nicely closed there. And that's the full closure. You can see that's how we open and close our case. Now, the approach that I think the real approach is that when you traditional post approach, most surgeons I think would repair the capsule with the trochanter, This is a non-anatomical repair. I always like it to compare to a putty plat operation. So those of the juniors who don't know about a putty plat operation, we used to do that for shoulder instability, where we used to double press the capsule. And therefore, the patient did not dislocate. Why he did not dislocate? Because he couldn't accelerate. And because he couldn't accelerate, he couldn't dislocate. Whereas we now know that's the wrong approach. So now for all shoulder dislocations, we do a Bankart repair where we repair the capsule anatomically. Yeah. So here you can see how the capsule has been repaired anatomically. So this one also has no dislocation, but the patient can internal rotate very well. There's no restriction of internal rotation. You can do internal rotation, but still don't dislocate. And that I think is the real advantage of using this approach in the TH. So the secrets of the post-lateral approach for the junior surgeons, it is 3 in number. The important thing is that I'll go through in detail the capsular release and the femur anterior subluxation maneuver, which I'll show you in detail, and how we position the retractors and what we call as 360-degree exposure of the acetabulum. I think every hip surgeon must expose the acetabulum 360 degrees. And once you expose it 360 degrees, hip arthroplasty becomes very simple. Otherwise, it's a very big struggle. So the capsular release goes in 2 steps. You first have to do an inferior capsular release. And once you are able to rotate the limb, you do an anterior capsular release. I will be showing this in the video very well. And then there's a femur subluxation maneuver. This also I'll be showing in the video. But just to explain things is that the assistant, this is the assistant, I am posterior, that's the limb held by the assistant. And the assistant is pulling the limb anteriorly and causing anterior translation when you internal rotate the limb. Okay, internal rotate when he's pulling anteriorly. And then you put your Homans. So when you put the Homans, the limb is internal rotated and anterior translated by a hook by the assistant. And when the limb is still in internal rotation, when the limb is still in anterior translation, as a surgeon, you have to external rotate and extend it, with the limb still being, the femur still being anterior translated. And therefore, once you do that, it tucks into the gluteus medius. It just goes like that into the gluteus medius. So this causes tucking in of the proximal femur. Suddenly, you'll find the proximal femur is nowhere in sight. It just disappeared from the wound, and you have the socket like a clock staring at you. That's the key. So you do this internal rotation while anterior translation, while holding the anterior translation, you external rotate, and the femur tucks inside like that. I'll show that in detail. Now, one point about the anterior Homans, it must be over the column, not the wall. Common mistake junior surgeons do, they put over the wall, and when the assistant retracts, it breaks the anterior wall. So you must go at the region of the anterior inferior iliac spine. It must be over the column, not the wall. Once it's over the column, it's very safe. Column is very strong, and as long as you go close to the bone, the femoral nerve and the neurovascular bundle is very safe, as long as you go close to the bone. So this is the video I'll show you in detail how it happens. So just stop the video for a second. You can see for the positioning of the patient, just for this thing, I have put the patient here. You can see that. That's how your perspective would be. So this is the head and ear. Anesthetist will be this side. That's my sacral support, and limb is this side. So we're operating on the left hip, and the limb is this side. So just to give you a perspective of this video, anterior would be that side. I'll be posterior surgeon. You can see the profile of the hip, how. So this is the superior side, inferior side, limb is here, thigh is here, posterior, anterior. So now we can get a perspective of the video. So I've done the skin incision. Come to the gluteus maximus. Now, whenever I find the gluteus maximus tight, I always release it. Not routinely, but when it's tight, and usually it's tight when the patient has got an external deformity or shortening. Now I'm trying to identify the gap between the gluteus medius and the peripheral. You can see that. And once I see that, I see retract that, I see the anterior capsule. Here there must be no bleeding. So I put periosteum under the gluteus medius and retract the anterior medius here. So we find that we don't damage even a single bit of the gluteus medius. I put this pin, the jet pin, over the capsule into the iliac fossa. And then we pin it there. You can now see that there's a nice corridor for me to work. So now I work on the short accelerators. You can see that. And let's say the short accelerators are teased out. We are not taking the entire quadratus at this stage because you hit the circumflex vessels and it will be difficult for you to coagulate. So for that reason, we only debulk it. We're not removing the entire. And here we find that you can see the capsule is nicely exposed. And this is the neck capsule preserving approach where I preserve part of the capsule superiorly. And this is the acetabular limb of the capsule. You can see that nicely. We are now preserving some capsule on the femoral side and some on the acetabular side. It's very important to take your capsule incision right to the cycloxar portion inferiorly. If you don't take that, you won't be able to move your hip. Now I'm putting a Bowman's below the muscle over the capsule so that I can get a good capsulotomy superiorly and anteriorly as well. So all over superior approach, I'm going to go, and now you can see that I'm now dislocating femur. Femur has now come out. Now I'll show you the capsular incision. It's very important. Is the first capsular incision inferior, and as the femur rotates, you now have access to the anterior capsule. So now you can see that very clearly. As long as you're under vision, it's very safe to that. Now I'm taking the anterior capsule off. Once you take the anterior capsule off, it becomes very easy. I've taken the head off, and now I'm putting my Bowman's. Bowman goes over the anterior column. And the assistant with this hook is anterior translating it, and now as accelerating it is still translated. You can see how the Bowman's was tucked under the head tucked under the Bowman went. I put all my other retractors there. So this is my ischial Bowman's. So this pin goes on the ischium. You can see that. Then we have dedicated Bowman's inferior. This is the antero-inferior Bowman's. This part of our hip set. And you can see that here. Now I put 5 instruments. That's the 5th one. This goes on the ilium pin. So I have my posterior inferior Bowman's and antero-inferior Bowman's. I have my that goes over the anterior column. I have to, now you can see how this is 360 degrees. All my hips, I want to get this 360 degree up there. Very critical that you get that. Once you get this exposure, it becomes quite easy to do any cerebral component. Can you see that 360 degree exposure? That's what we want to do in all our hip arthroplasties. So the question I'd ask is, so you know the posture approach very well. Should you keep innovating on it? I think we should. And even after doing 4,000 hips, now I think every day I want to learn more, and every day I'm looking at it very keenly and seeing how I can improve that little bit, how my posture of the Bowman's can shift a little bit, how I can constantly keep improving that. And that I think is very important. A lot of surgeons sort of do it mechanically, but I think we should keep innovating in that. Very important. I always compare to driving a car. We all can drive a car, sure. But then if you take, these top guys, Lewis Hamilton, etc., now they can drive better. Although, it's all end of the day, it's all driving a car. You can still get better and better and better at driving a car. So like that, in your hip surgery or any surgery, although you know the steps very well, there's a lot of room for innovation, and you must keep getting better. Every day must be a learning day for you at the OR, and every day I feel I'm learning my approach and I'm refining my approach all the time. So constant innovation is the key. Try and you're trying the innovating the approach as we go along, and we have to hopefully design implants and instrumentation and facilitate that. And of course, we also have to improve the accuracy of component placement. So I think that although THR, TKR has become routine surgery now, there's always room for innovation and improvement. And I think all surgeons must always be constantly striving towards that. Okay. So that's the thing on the posture approach. Thanks, Kiran. I'll stop sharing.
Hey, thank you very much, Vijay. It was excellent talk, and you demonstrated very well the key important points that the positioning is the key. You don't want the patient to wander on the table. That's number one. And you have done the operation in different centers also. But because you are involved in the positioning, and I remember very well in Ruby Hall when you came, you were very, very particular about the posts. And I think that is the number one message for everyone to take home. And of course, I know you've got your own set of instrumentations and sort of implant tray you have designed for this particular thing. And I think we can talk about that also in the discussion. And I welcome Dr. Nikhil Shah, Dr. Narinder, Dr. Surendra, Dr. Vikas, to come with their points and inputs in relation to your talk. So who wants to take it first? Nikhil?
Yeah, so excellent demonstration as always, Vijay. Very, very clean surgery, very experienced surgery. So like you, I also like to position the patient myself. I think that is the key, because if the patient moves during surgery, you can't really blame anyone if you haven't positioned it yourself. The second tip is about the gluteus maximus tendon. Again, like you, I release it every time I feel it is tight. And in 9 out of 10 cases, I find a reason to show that it is tight, especially heavyweight muscular patients, obese patients. And Dr. Ranawat wrote a very beautiful paper, cadaveric studies of the MRI scan and the gluteus maximus and the sciatic nerve. And he describes what is called as the sling of the gluteus maximus tendon, which pinches the sciatic nerve. And that's how he proved that even with a Harding type approach, even though you're nowhere near the sciatic nerve, you can still get a foot drop. So I think that step is critical. And the third very useful tip is to keep the hip extended and the knee flexed. Many purely trained arthroplasty surgeons who haven't done acetabular fixations, they tend to let the hip go flexed and the knee extended so that the foot is lying on the opposite edge of the table. And that causes a lot of stretch on the sciatic nerve. Whereas if you extend the hip and flex the knee, the femur relaxes, the nerve relaxes, and in fact, the exposure improves. And one final point is, how do you repair the rotators? I saw how you repaired the capsule. What do you do with the short external rotators? Do you repair them or leave them alone?
No, we repair them, yeah. So we repair the capsule anatomically, and then we tag the short external rotators as well. The two separate layers, we do that. I'm sure the short external rotator closure does not aid your your stability, but it's always good to close everything anatomically, I think.
Yeah. Do you repair that to bone or to the remnant of the soft tissue?
To the remnant of the thing, yeah. So we don't take any sutures through bone at all, yeah.
Okay. Vijay, just about the use of pins as retractor. I see that they use a couple of pins as retractors. Have you ever faced any fractures through the pin tracks? That can sometimes be a stress riser.
No, I think the earlier Charnley pins, which I still think they use in Wrightington, they are very high profile ones, yeah. So the ones that in most other centers they use is the Judd pin, as we call it. That's very low profile, and I haven't seen a fracture at all, yeah. And I use it extensively in revision surgery. It's not only a retractor for me; it's a great retractor for me because we are subcapsular, it is safe. But more importantly, it tells me where the bone stock is. So because the pins tell me where is good bone, I know, when I'm reaming in the revision situation, I know there's good bone there. I can move here, there. So it's not only a question of the pins are useful not only as a retractor, but it tells me where good bone is in revision surgery.
Yeah. Excellent demonstration, Vijay. First few points which I wanted to add on to the posterior approach and then few questions to you. So when we start off the surgery, as rightly pointed out by Vijay, we really want to know exactly how the patient is positioned. Many times somebody else has positioned, but you need to check. One thing which is important and pertinent to know is you should be familiar with the table also which you're using. And many times you change your OR, sometimes you're operating in somebody else's setup, especially in private sector. And for us, when we change our hospitals, the table width also matters because you need to be able to get your knee off at times. So you need to be freely be able to position the hip in all position which you want when finally you want to check the stability of the hip. So this is something we usually check: the knee to knee position, knee off the table position, check for all the bony prominences, whether they are properly, where they are, how they are palpable, to get your orientation throughout the surgery of the patient while the patient is draped is by these bony prominences. Even feeling the sacrum with the flat of your hand to get the hang of the angle of the sacrum, because sometimes it also helps in positioning of your cup, the sacrum itself. So positioning is important. Check the width of the table, check that there is nothing impinging. So when in the end you try to check the dislocation or your combined version, you sometimes trying to adduct and see the laxity or feel for the position where it dislocates. Some of these positioning devices can also obstruct the movement and lever out your hip, giving a false impression that it is unstable. So check all around the hip that it should be free. Check your table and ability to move your hip all around. Skin marking is important. All bony prominences to be marked. And as Vijay pointed out, that you need to gradually learn how to control your incision and in relation to all these bony prominences. It also helps you in using your reamers where you are by having a fair idea of ASIS, PSIS, the cone where you want the screws to go in. All these things in your mind should keep acting when you do these skin markings, and then try to follow them and keep a track of them while you're exposing and operating on the hip. Regarding the exposure, essentially, we use the same as Vijay pointed out, a standard posterior approach, keeping the gluteus released depending on the patient and how much you need it. Releasing it helps when to prevent, to facilitate the moving the femur out of your view, and even protecting the nerve at times, because palsy rates are more if that band is tight, as pointed out by Dr. Ranawat. Regarding the all-around 360 exposure, we use pins frequently at 12 o'clock, and then we do a episiotomy around the tal, which helps in inferior exposure. We use the pins even in posterior inferior if the bone stock is good, and as indicated by Vijay, it also helps us to tell how the bone stock is. I wanted to now ask Vijay that in his career, has he from day one till today restricted himself to posterior approach, or he has been changing over, or it took some time to precipitate the posterior for posterity?
Right. Now, so as MS orthopedics, we were taught posterior for hemiarthroplasties and all that. But I went to the UK, I didn't see any posterior approach. Everything was Hardened type approach where I trained in Liverpool. So I shifted to that. And then when I went to Birmingham and then I learned the resurfacing, we went back to posterior. And then once I learned to do resurfacing, where we expose the socket without removing the head, I knew this was a great way of doing things because, you have so much extra room there. So they're able to expose the socket without even removing the head. So I stuck to that. And I haven't had any need, apart from the few steps where sometimes I go dual approach, I haven't had any need to go to an anterolateral type approach. So I stick to that.
So I also feel that although you need to stick to one approach which you use, but knowing others also helps because it gives you all the perspectives around, because ultimately it is looking in front of the femur or from behind. Like one of my teachers, Vijay Raskina, had taught me, and he so easily switched from one approach to the other. And he said it's just about looking the femur from for the cup from front of the femur or behind. So once you get used to both the views, you're quite comfortable, and then you select one which you can do reproducibly. So maybe the youngsters, when they in their career, of course, in the beginning, stick to one, but learn the other, or at least attend others, and then decide which you want to choose. And knowing the other also helps in overall management of your cases. Any role? Do you ever use any positioning aids for your acetabulum and navigation or and then would you change your approach? Or you?
We are in the process of developing indigenous navigation that we are developing now. We're doing a lot of work on that. But I have tried all possible hip navigation so far that's been on the market. I've been very intense in that field, but I have found singularly they have not helped me improve my compound positioning in any way. So we have left out, and now we're just waiting for we now have the robotics that we use with the knee, and they're just bringing in the hip module now, must be a month or two. So I want to see how that works with the Smith & Nephew. But this hip navigation that we are developing is quite independent of that. This is a concept that we have had for a very long time. But I think finally we have, the thing is almost ready for use. Let us see how people would find that very useful.
Can I have one comment on navigation?
Yes, Nikhil.
Yeah, so as rightly pointed out, none of these navigation systems have been particularly useful. One of the things that people need to understand is the difference between accuracy and precision. Accuracy is where we implant the cup, for example, which is the best position for that particular patient. And precision is the ability to implant that particular cup reproducibly in the same exact manner that you planned. What navigation does is it improves the precision. So if you want to put a cup in 20 degrees to the floor or 20 degrees to the ceiling or whatever your parameters are, then the navigation will stop you from going to 18 or 22. It will ensure that you will put it in 20 degrees in every patient. What it does not do is improve the accuracy. And the reason for that is we don't know what accurate positioning is for that particular patient. No one knows what is a normal cup position for one patient from the other patient. And that is the reason why navigation has been singularly unhelpful. The second problem is you might think that your cup is very accurate when you put it when the patient is in the lateral position. But sometimes the spinopelvic alignment, the spinopelvic tilting, the rigidity and stiffness of the spine completely change the position when the patient stands up. And that is why many times in a dislocated case, your component positioning is actually very good. And in many of the patients where the component positioning is not so good, they don't dislocate. So it's important to appreciate the limitations of navigation because, like you said, a lot of that is used in marketing rather than in developing the science.
Like we discussed in our last one of the meets, that in the end, the better way is to look at the combined version and give a movement, check the movements, check the impingement, check the levering out, or those factors. I think combined factors are much more important.
Yeah, I call it a cerebral cortical navigation.
Yeah. Just one more point I wanted to add in the approach, that sometimes the youngster is in a hurry to dislocate the hip. So the moment he reaches the hip, sees the femoral head, he dislocates. So that is something which should be resisted, and you do your approach well, you do the clearance all around, and it is not after the neck cut that you go back to the approach. So clear things around, and then you could dislocate and go further ahead. So that is something which helps.
Just a few more comments before I come to my as Vikas mentioned about the width of the table. This is particularly important if the patient is very thin and very small. And if you are not there in the positioning and your assistant positions the patient, if the patient is more towards the front of the table, it is very, very tedious for you as a surgeon standing behind the patient to get into the hip joint. So it's very, very critical in very thin patients to know the width of the table and to adjust a patient in such a way that you don't have to lean forward too much to get inside the hip. That's one point. The second point about robotics, I actually saw the Mako in use when I went to Australia. And one thing which is good is that it gives you a three-dimensional view of the acetabulum. So it is very good teaching tool, I think. But as Vijay said, if you do the basics right, and it is definitely an add-on when it is more evolved and less costly, and less bulkier. But at the moment, doing these tricks which Vijay showed in the posterior approach should help us.
Not only that, Kiran, the fundamental conceptual difference between navigation in the knee and the hip. In the knee, we don't know where the hip center is for a mechanical axis.
Yes.
So the navigation tells you where it is. Whereas here, I'm not putting the cup in relation to the SI joint or the L5 vertebra or anything. I am putting it in relation to the local anatomy.
Absolutely.
So I have to tell the computer where the local anatomy is. Then there's no point in the computer again telling me what I am doing, because I have told it. Whereas in the knee, it finds the hip for me.
Yes.
It finds hip for me. And therefore, it adds value. So the only way it will add value is when you do a CD based, where it gives you information that you don't know already. And therefore, in revisions, etc., it suddenly has got a role, and that's what we are developing.
Yes.
As it is internal navigation, we call it, when we are looking at the tile and the pubis. And so we are able to navigate the cup reasonably well in a primary scenario. And that is why maybe it is not picking up the navigation.
One of the pioneers who was developing the Mako, this was about 7-8 years ago, which I happened to meet at a meeting. I don't need to take any names. And I told him, what do you think about the Mako? And his words to me were, if you use the Mako, you can make a lot of money.
That's a good one.
Okay. So Narendra or Surendra, any points?
No, I just want to add something that as we had discussed about the proper positioning of the patient and the vertical positioning of the sacrum, very important. One more point is that many of the places where you don't have a fully automatic operation theater table, where you can go on a zero setting position, where the table automatically gets into absolutely parallel to the ground, no inclination, no tilts. So at times when you don't have this kind of operation theater tables, then one need to be very clear, but need to be very certain that the table is perfectly parallel to the ground. There's no tilt before you put a drapings and all that. Because once you put a drapes and all, then at times it becomes very difficult to understand whether there is a little bit of tilt or there, or some inclination is there, which can alter all our versions parts. So I think that is one more point out of it.
I have another question for Vijay. Vijay, a lot of time we have to increase the horizontal and vertical offset of the hip. At that time, it's quite tough to close the capsule posteriorly. what's your approach to close the capsule at that time?
Well, if it cannot be closed, then obviously that's fine. We just leave it like that. But what we don't want to do is, typically when you increase the offset or increase the length in a patient who is already shortened, that patient is a candidate who's not going to dislocate because you have lengthened him. That's why in a Crow 4 that we always put 22 head and it doesn't dislocate because you have lengthened him significantly. So that patient who has a stiff hip, you're not able to close the capsule, you have lengthened him, he's not a candidate who's going to dislocate. So we forget about it. The advantage of closing the capsule, the way that I showed, is that in a normal patient, especially a female patient who is very lax, you take the capsule and put it to their trochanter. And therefore, you have shortened them artificially. And they don't like it. I mean, not every patient, but I'm talking about a very active patient. They will complain about that. They're not able to interlocate. We have had many patients like that. And that's why we think that's very important. But the patient that you described, when it's very tight, previous fibrosis, lengthen the patient, we won't be able to close the capsule, but that's fine. That's not going to cause dislocation.
Okay, what I personally do is that I just close the capsule superiorly as much as I can, but no attempt to close it in any external rotation contraction. Just the superior bit only.
Yeah, that's a good point. Yeah.
So Vijay, you have what all changes you might have done to your posterior approach over last 10 years? Have you done any? Or
that's what I told you. Small things here. The neck capsule is probably the primary thing that we did. That has worked very well in our hands, and we have not had any dislocations, touch wood, apart from the two that I told about. So that's been good. So posterior has been very good in our hands.
Another thing which is very famous about you is your bursa closure. Not many people do that. Laurie Cohen showed me how to do it. He told me that Vijay taught me how to do this.
Yeah, that's a good. Now, if you really meticulous and especially if you close the bursa, next time when you go in, for whatever reason, you find it's like a primary. It really is like a primary. You can dissect the planes again and things like that, and that makes you feel good. But I'm sure that it doesn't add to stability or anything like that.
I think the big advantage of closing the bursa and by just incising it very cleanly is, this is anecdotal and I can't prove it, but I think there is a reduced incidence of trochanteric scar pain post-operatively if you close it nicely and finely.
I think we have, discussed the posterior approach, and it's time to look at the direct lateral approach. And this approach is going through the gluteus medius minimus and over the greater trochanter, and then you access the capsule. The Americans tend to, confuse it by calling it the anterolateral approach, but the true anterolateral approach is called the Rottinger approach, which goes between the tensor fascia lata and the gluteus medius. So, which approach to choose as a budding arthroplasty surgeon? I think the answer is very clear. The posterior approach, one has to master it, but the hip surgeon should also know the direct lateral approach, because in one paper, V.K. Agarwal pointed out that there is a direct correlation to complication rates, and therefore you should choose the best approach and master it well. So mastering an approach means right from the positioning and knowing where the pelvis is at all times. An interesting paper in 2020 by Ashley Blom in BMC Medicine, they looked at more than 7 lakh hips in the NJR, and they grouped them in 7 groups, namely the conventional posterior, the lateral, the anterior, the transtrochanteric, the minimally invasive posterior, the minimally invasive lateral, and the minimally invasive anterior. And they looked at survival methods, looking at revision rates and 90-day mortality. And in their study, the lateral approach had the worst outcomes with more deaths and revision, and they recommended the posterior approach as the standard approach. But what should the ideal approach be? Like Vijay said, it should give you a good exposure, and you should be able to reproduce it consistently. And one must learn to evolve and improve it every time you do it. The approach should be bloodless, it should be preferably internervous, and should allow the patient to recover well with minimal complications. So you cannot say I'm just a posterior approach surgeon or I'm a lateral approach surgeon. You should be well versed in all approaches, and I admire Nikhil and Mahesh Kulkarni and all the pelvic surgeons because, being pelvic surgeons, they are well familiar with all the approaches. And I think spending some time with such people will always help when you do hip arthroplasty. So any approach, the paradigm is to handle the vessels, nerves, muscles, and all the fascial structures very, very carefully. It is called as reduced soft tissue trauma surgery. You have to create a good view of the operative field, and you should be able to maneuver the hip in such a way that there is no obstruction at any given time. And one should be able to extend the approach if there is tightness during the procedure. So the hard hinge approach is very, very popular. Cocker described in 1903, but McFarland and Osborne in 1954 elaborated on the anatomical principle that the gluteus medius and the vastus lateralis act in functional continuity by their connection over the greater trochanter in a very dense fascial sheath, as you can see in this diagram out over here. This is the fan-shaped gluteus medius, and this is the vastus lateralis, and this is the sort of the conjoined fascial tendon. So the hard hinge approach was introduced in 1982 with the advent of the PCA hip by Howe Medica, and the original approach described to elevate about 50 to 60% of the abductor from the greater trochanter. But there were many modifications along the way, and one of the sort of popular modifications, especially if the tendon is very, very flimsy, is the Dahl et al. Modification, where bony fragments are elevated as you elevate the abductor. And you can use very, very sharp osteotomes or chisels to do this, like a Femister grafting technique. Further modification has been by Frindak et al. And Head et al., where they reduced the amount of abductors released from the trochanter, and they only released up to 30%. And their rationale was that doing this, they preserved most of the abductor strength and therefore reduced post-op limp and reduced post-op heterotopic ossification. There's an interesting chapter by Lombardi in the surgical treatment of hip arthritis in the book by Hozak and Parvizi, where he described using it even for revision THR also. But why traditionally choose the hard hinge approach? Well, the literature shows that there is a lower rate of dislocation. And even though it is not a true internervous approach, it is an intermuscular approach where the gluteus medius is split distal to its innervation of the superior gluteal nerve, and the vastus lateralis, if needed, is split lateral to its innervation of the femoral nerve. The most famous meta-analysis is by Mason S., where they looked at 14 studies and more than 8,000 hips, and the dislocation rate was as low as 0.55%. The other good thing about this approach is if you can do this approach with the patient lying supine on the table or in the dead lateral position. When I was in the UK, I trained with one consultant who did all his hips in the supine position. And this particularly helped in very, very obese patients where there was a lot of soft tissue and a lot of adipose tissue. And what we used to do is bring the patient on the edge of the table and put a sandbag under the buttock. And that, immediately gave a very good, all the soft tissues fell down, and one could easily do the modified hard hinge or the hard hinge approach in the supine position. Or one can use a dead lateral position like Vijay showed. And again, it's very, very important to position the patient yourself so that all the restraints are applied properly, and you have to test it that it doesn't move or rotate, so that when you're in the middle of the operation, the patient will fall off and it will give you a very warped view of the hip inside. So it is very important that you take the skin incision centered over the greater trochanter, like shown here. And when you come to the deep dissection, you start off by leaving a very, very good cuff on either side of the gluteus medius. It is important you can start the dissection at the middle of the greater trochanter, or as I do it, at the inferior part of the greater trochanter. And then if needs be, you can extend it through the vastus lateralis down, but always beware of the branch of the lateral circumflex artery, which is always there, and you have to cauterize it, or you have to, tie it up. I sometimes develop an anterior flap with underlying bone using sharp osteotomes, especially if I find if the tendon is very, very flimsy. And then I use a sharp dissection using a cautery and elevate the gluteus minimus from the anterior greater trochanter. Sometimes a stay suture is required, especially in very, very large patients, when I can anticipate that when I try to dislocate it, the dislocation can tear off the gluteus medius and may cause iatrogenic superior gluteal nerve injury. And this is how it looks when you do the hard hinge approach. There is a stay stitch here, and you can see the head which is delivered. There's a Homans trying to deliver it out, and the abductor is behind the Homans. It's very, very important to handle this muscle very carefully, especially in the stage of dislocation. And you must always guide your assistants to not flex the hip too strongly, because by doing that, you can tear off the muscle and it can become very, very unwieldy to repair. So I think as the surgeon, you have to guide the assistants how much flexion is required, how much external rotation is required at every stage of the operation. Why is it important? Because in this approach, you invariably retain the posterior capsule, and that automatically reduces the dislocation risk. And also, you don't invariably lengthen the hip because the posterior capsule is always there. And you can get an excellent acetabular exposure without compromising the pelvis. And if you repair it properly, then the chance of limb and heterotopic ossification is reduced. But yes, there are contraindications to this approach. And there are two contraindications you must keep in mind, especially if the patient had a proximal femoral fracture which has healed in flexion, then you cannot do this approach. And if there is lengthening of more than 2 centimeters anticipated, then this approach should not be used, because you cannot bring the gluteus medius and attach it properly. I won't deal in this pre-op planning because this is taken for granted, and our previous webinars have covered it very well. So let's look at the sequence of events. The first is the skin incision. You start it about centered on the greater trochanter, and it is important to curve it back slightly in line with the gluteus maximus. You can see the tensor fasciae lata and the ITB, and this curving of the incision in the tensor fasciae lata is very important to avoid a tight sling. And this can really jeopardize your operation, jeopardize the movements and the maneuverability of the hip. And like Nikhil and Vijay pointed out, this can also cause later on, if the hip is very tight, sciatic nerve injury. And the assistant at this time, gently abducts the leg and externally rotates the leg. But if you don't curve the tensor fasciae lata incision, mind you, it will be a big problem with this tight sling as the operation progresses. And here you are, you can see that the tensor fasciae lata, you've got to curve it down so that the sling is not formed and you don't compromise the operation. Then you come to the deep dissection. And at this stage, I put a finger under the gluteus medius to free it from the undersurface of the capsule, and then start the dissection from distal to proximal, making sure a good strong cuff is left on either side of the gluteus medius. And then instead of going up superiorly, where the superior gluteal nerve can get damaged, it is important to turn the incision into the muscle belly, and not more than 3 to 5 centimeters is required. Then the attention comes to the gluteus minimus. But here in this slide, you can see I have put a Charnley retractor and identified the gluteus medius. A stay stitch is always used by me, and I start the dissection in between these stay stitches right down on the greater trochanter, and this way invariably a good cuff is left behind. Many times I palpate it before I do this and commit myself to see how thin the tendon is and whether I need to take flakes of bone which will augment my repair later on. Then the Charnley retractor is repositioned and the leg is gently rotated externally and it is kept in a pouch in the front. Beware not to flex it too much and too harshly or with too much vigor, because that can tear off the gluteus medius. And when you come to this stage, this line diagram shows that you come to the capsule and you can see the gluteus minimus down there. The capsule is released, and the way I do it is like a T-shaped incision where the vertical limb of the T is along the neck and the transverse limb is along the ridge of the greater trochanter. And here you can see in this diagram, this is the vertical limb, and by digital palpation, you can know where to cut it. And then this transverse limb is along the trochanteric ridge. And by doing this, you can really elevate two good flaps of capsule. And these have to be excised in a total hip replacement. But if I'm doing it for a hemiarthroplasty, I try to save it till the end. And when I do the final reduction, I usually use a stay stitch to repair the capsular leaves. And then I proceed with my abductor repair. So again, I stress this point, avoid excessive flexion because that will tear the abductors. And sometimes you can use a bone hook under the neck to lift the leg and to lift the neck and gently deliver the head so that you don't tear the abductors. And here in this diagram, you can see the abductors are well preserved in the front. A bone hook has been used, and by gentle maneuvering, I can elevate the head out of the acetabulum into the wound without tearing off the abductor. And the stay stitch is very well applied. It is still there, and you've got to keep on checking it till the end of the operation that it doesn't fall off and you don't lose your landmark. Then you use your Hohmann retractors and you probably apply them like Vijay said. These retractors should be placed by you. You should not give it to your assistant. And I always say it is walking of the retractor over the bone. So you walk the retractor over the bone and then you slide it over the brim. Like Vijay said, make sure it's resting on the column and not on the wall, because if the retractor is sharp, if your assistant is very strong, and if he puts too much vigor in it, you can actually lift off the anterior wall and compromise the entire operation. I sometimes use Steinman pins, but I don't usually use it all the time because in this approach, I rarely need to use it. And see that if you do a proper hard hinge approach, this is with the posterior approach, you can get this view. And with the hard hinge approach, you can get a 360-degree view of the acetabulum. You can see the tal, you can see the anterior, the posterior wall, the superior wall, and the retractor placed strategically can remove the femur. And this retractor around the 2 o'clock position or 3 o'clock position is safe. And you have to walk it over the brim. You place it and then ask your assistant to hold it with a digit, not with his grip like this, but with a digit or a swab through the holes of the Hohmanns so that there's no pressure on the anterior wall. So these are the retractors I commonly use, a Charnley retractor. I often have a Norfolk and Norwich retractor or a small West retractor, which is double angled. And this won't come and compromise your view in any way. And this is how I can see the acetabulum very, very clearly. The photograph is not taken properly, but you can imagine this is the retractor where the tal is. This is the anterior retractor. This is the Norfolk and Norwich retractor. And you can get a circumferential view of the acetabulum and you can proceed with the dissection. This cross-section shows that the retractor has to be placed on the column, not on the wall. You have to walk it along the bone so that all the vasculature is safe, especially the anterior one out over here. The femoral artery and the vein and the nerve are safe if you properly place it, and you can get a good circumferential view and you can do the reaming and all the operations properly. So the common criticism is that the patient limps, but I beg to disagree. If you do a proper repair, if you don't damage the superior gluteal nerve, this won't happen. And in my practice of more than 25, 30 years, I've hardly seen this complication. You can use non-absorbable ethibond, and the assistant should abduct, flex, and slightly internally rotate to remove the tension. Sometimes you can oversew it with 1-0 absorbable sutures, and sometimes you can use osseous bites. Less important modification is that there is no transgression of the vastus lateralis. This patient, a very young girl I did, 22 years old, it was a fused hip, and I unpicked the fusion. And at that time, more than 15 years ago, we didn't have the Biologs Delta ceramic. It was a very petite patient, so I had to use a 22 millimeter head. I used a Depew Corail alumna head and alumna lining and a Pinnacle cup. And this patient is doing well for 15 years. And this video doesn't run, but she walks very brisk and there is no limp at all. So conclusion is that the dislocation rates are certainly low. You look at any literature and it works well if it is repaired well. There's an interesting paper which Vishal Rajput told me about, Martin Parker. I worked with him in Peterborough, and he looked at a randomized trial of 216 patients, and he said that the posterior approach was technically difficult in this study, but the overall outcomes was good, and the patients did well after being followed up for a year. Another interesting study in 2018 from Acta Orthopaedica, they looked at the bone mineral density, and they found that periprosthetic bone loss was more in the direct lateral approach as compared to the anterolateral approach. And they found that in all the Gruen zones, there was reduction in BMD after 3 months in the direct lateral group. Now, we know that there is remodeling which happens after we do a total hip replacement, and it is multifactorial. No matter which approach you use it, the rasping, the design of the stem, everything influences the remodeling and the bone strength in that area. Churchill had a paper in 1992 where they looked at cadaver perfusion studies, and they found that the gluteal blood vessels can be damaged if you do the lateral approach directly. And what is the significance of this? So again, like Vijay said, you have to evolve, you have to improve every time you do a hip replacement. And what does it mean? You do reduce soft tissue trauma, you handle everything well, you don't dissect roughly, you try to preserve the blood supply, because if the bone density is lessened, there is a higher chance of periprosthetic fracture in the first 6 months. So friends, the conclusion is that if you want to be a hip surgeon, you must master the posterior approach, but you cannot overlook the lateral approach. In the NJR, the lateral approach was the second most common approach. 36% used it, while the posterior approach was the commonest approach. And you cannot convert a lateral surgeon to the posterior surgeon because, it takes a complete different orientation to do it. But fortunately, I was trained in the UK like Vijay was, and I'm happy with the posterior approach or the direct lateral approach. But if you have a choice, the budding surgeons should master the posterior approach and should learn it on cadavers by assisting the masters, and also learning the lateral approach very well, because it is an important approach to have in your armamentarium. Now, with this, I end my talk, and I have very short videos to share. Let's see if I can get them here. This is a short video showing the skin incision. You can see that be very, very gentle with the soft tissue handling. Use retractors very judiciously. I've put a curved artery under the gluteus medius. The head end is on this side. The foot end is this side. The stay stitch is done always by me. And by doing this, I can go in between the stay stitch vertically on the bone using a cautery. And this is the thing I'm saying, that going into the muscle belly prevents you damaging the superior gluteal nerve. And you can go down into the vastus lateralis if required. And in this patient, I had to do it because I knew it was a very tight hip, a very, very big hip, and I anticipated that problem. So once you do that, you start elevating the gluteus medius, and here I'm on the capsule. I have taken a vertical cut along the neck and a very, very thick capsule in this particular osteoarthritic patient. And you can see in very, very large heads, the dislocation can be a big problem. Here I'm cauterizing the branch of the lateral circumflex artery. And you do the neck cut, but sometimes even after doing the neck cut, you cannot dislocate the hip easily. And this is what I mean, that if your assistant flexes the hip at this stage, or if you are very, very rough at this stage, you can damage and tear off the gluteus. So what I do is I use a Homans as a levering tool. I maneuver the head inside, and there you are, a complete circumferential view of the acetabulum, which can be seen. The swab is inside, and there is no compromise on the view there. That is one video. In this video, I directly want to go to the closure, and I will drag the cursor to that part. So the closure, you can see that the stay stitches are well in place. Once I've reduced the hip, I've got good cuff of tissue, and I start the closure at the level of the stay stitch. And here the assistant is gently flexed, abducted, and internally rotated. And you can see that I can get good cuff to cuff approximation with excellent tension on the repair. And I always aim for this repair to be a watertight repair, so that, once you put a digital palpation on it, you know that it's a very, very strong repair. And you can augment it in between by osseous bite, especially if it is a very porotic patient. You can go through the trochanter with your needle without having to drill any extra hole through it. And you can see that this repair is very, very strong. And then you come down to the vastus lateralis, and again, you can close it like Vijay says. You have to open it very meticulously, and you have to close it very meticulously. In this video, I used to use a drain, but nowadays I've stopped using the drain, and I'm sure all the modern surgeons have stopped using the drain. This is the tensor fascia lata. I use it in a sort of a continuous stitch, and then I close it in layers. And you see that the forceps doesn't pinch the skin. It is just giving me traction to allow me to put the needle, so there is no damage to the skin when you are doing this aspect of the closure. You can use staples, or you can use subcuticular sutures. And the last video, which is a very, very short video, is to show how to do this in a fracture neck scenario. And again, I will bring the cursor to the skin incision. This was a live demonstration in Kolhapur Medical College. And like Vijay said, you have to position the patient yourself. Otherwise, if you don't do that, then it can be an issue. So once you do the proper prep and drape, you can see the hematoma out over here in the fracture situation. You have to palpate the greater trochanter, and you start with the skin incision centered on the trochanter. You have to utilize the incision completely, and the aim should be that there should be no U at the end of the incision. So it should be always a V, so that there is no excess stress and damage to the skin. So it should be of sufficient length and should not struggle with smaller incisions. That fat is gone, like Vijay said. And once you do that, you can see that the soft tissues are very, very pliable here. And you have to clear it and then put your retractors in place. Many times I use a swab to protect the soft tissues, especially when you are tightening the Charnley retractor to expose. And you have to place it in such a way it gives you a very, very good exposure. Now you can see I'm again doing the stay stitch. The orientation is the leg is that side and the head is this side. And I always use a stay stitch by after putting an artery under the gluteus medius, and this stage stitch gives me the lighthouse to make my cut as I'm defining it here with my cautery. It has to be done vertically, and it has to be done very, very meticulously. You cannot rush this step, because if you rush it, then you won't have a cuff. And you can see in this video from a different angle, the cuff, you can see a very, very thick cuff left behind on the greater trochanter. This is the vastus lateralis there. There is the ubiquitous branch of the circumflex artery, and the assistant is gently externally rotating. And by doing that, you stress the gluteus and you can gradually dissect it out, and you can expose the underlying gluteus minimus. And again, take a lot of time. I can often take up to 15 minutes or more in this particular stage, particularly if the tendon is very, very tenuous. And here you can see the bleeder has started making its presence felt, and the circumflex artery has to be cauterized, otherwise it will leave a hematoma behind. I'm gradually extending in the front of the neck, and the assistant is gently externally rotating, as you can make out on the tension on the gluteus medius. This artery clip is removed at this stage when I come to this point, and when I do this, I expose the front, and here you are. I'm using a Cobb's-like elevator, and by doing this, you can see the gluteus minimus and the capsule. Many times I can just repair it separately, but you can use the incision to make a conjoined cut through the gluteus minimus and the capsule, like I'm doing here, right on the neck, vertically down, the straight limb going down. And in this perspective of the camera, you can see very nicely, as I'm doing this, the fractured neck is exposed. This was an old fracture, so I had to do the gluteus maximus release at the beginning, which I didn't show for want of time. And the transverse limb of the T is along the greater trochanter. And you can see as the assistant externally rotates, the neck pops out into the wound, and you can get excellent leaves of capsule. So this is the inferior leaf, which has been held by the forceps here. And in the bipolar situation, I preserve it till the end, and I make sure that I close it. And this gives me a very sound sleep, knowing that I've got a secure repair. And the hard hinge approach by itself has a reduced risk of dislocation. But by saving this particular capsule, like you can see, I'm grasping it with the cockers, and that is the one limb of the capsule. And by retracting it here, you can see the other limb being grasped by the cockers. And this can be preserved in the hemi-arthroplasty scenario. And here you are. So why it is crucial? You can see the soft tissues are very pliant, very, 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 very soft. And therefore, the balancing of the hip is very, very critical in a fractured neck situation. And these capsular leaves have to be preserved till the very end. So with this, I end my talk and welcome for comments from the panel. Thank you very much. Okay, so
Kiran, it was a very wonderful explanation about the about the direct lateral approach. So I invite Vikas or Nikhil to do some comments.
Yeah, it was a very lucid demonstration of with videos of the direct anterior approach, which Kiran gave. Just a part of my training. Initially, we in our residency, as usual, we all got trained in posterior approach. Usually, most of us have done that. But as a part of my arthroplasty training in one of the high volume centers of armed forces, with our boss back from the UK and Europe, he was doing only anterior, the direct anterior approach. We used to call it a Muller modification of the direct anterior lateral approach. So got to do that for almost 2 to 3 years. And then when I got trained with Dr. Anavath and in endoclinic, I realized that posterior approach was the most favored approach and went back to the posterior approach. And in between, I met this surgeon, which I told you, Dr. Vijay Raskina, who fluently told how to manage the two approaches, how to discern the anatomy from both sides. Because what I feel is the acetabulum looks almost similar once you translate the femur posteriorly. So acetabular look is same, whether you see it from anterior approach or the posterior approach. All-round exposure, 360-degree placement of retractors, ability to get the right version automatically to an extent, because your hand always remains anterior, or the native version is easier with from an antro or direct lateral approach as compared to posterior, where consciously going by the landmark you have to do it. That is one difference I felt on the acetabular side. But more so on the femoral side, one has to really get used to the two approaches, because the femoral landmarks are different. Posteriorly, what you calculate as offsets from lesser trochanter are not similar anteriorly. You got to palpate the ridge. The lesser trochanter is far back. You somehow get the hang of the lesser trochanter and follow the ridge to mark your, because you not need to restore the offsets. So restoring offsets anteriorly, a better landmark is the depth from the GT tip. So these are the few cues. The cues on the femoral side are different to restore the femur when you're doing the direct lateral approach as compared to the acetabulum, which essentially remains the same. And positioning of the cup is more innate and more native when you go from the direct lateral approach. This is what is my experience been, doing about 3 to 4 years of one approach and then almost 15 years of the other. But flipping between the two can be a little challenging, but in younger days, if you get used to the two, you will be able to orient yourself well. That is something which is important. Regarding the approach and the videos and the steps, essentially our steps are similar. The only difference is that we take the whole flap as one. That helps us suture back the flap easily. So we are not been dissecting out the muscles like the minimus separate, then the capsule incision. We have been taking the whole flap like Kiran showed in his last video. So the flap restoration back and suturing back is almost watertight. We almost always go into the vastus lateralis, and we make sure that the usual mistake done by a beginner is not taking adequate gluteus medius, because being a posterior surgeon, when you go onto the direct lateral, you are scared of violating the medius. You keep thinking about the medius. Medius is all around the trochanter. It is not just the anterior part. So when you take significant amount of anterior part, still you have taken just about 1/3 or maybe a little more than that. So you need to take an adequate amount so that you don't struggle and damage the medius more than what you would have by cutting and suturing it back. So that is something which you should be aware of. So layered exposure is something which we have not been doing. One flap, taking adequate medius, get used to the anterior anatomy. In the end, the restoration of the offsets, the tests which we use for the posterior are little, may not convey the same meaning in the anterior. The combined version is little tricky. The shuck test is, need not be as precise because of the inherent stability of that approach. So these are few things which are different. We feel translating the femur posteriorly is a different trick. So that also needs to be learned by where to place the retractor and what force to apply, and at that time how to take the limb into the pocket. That Kiran has already elucidated well. So all in all, this approach is useful to learn it at younger days, and to keep it in your armamentarium serves you well. Extensile wise and for revisions, I think posterior remains a better approach, although those who have been sticking to one, like I remember when I was in this army hospital and I was used to posterior approaches, and my boss said, okay, Ghost, come on, from this incision I will not be able to do my anterior, so you better carry on with your posterior and now I will assist you. So I realized it's an handicap to actually know only one. So knowing the other helps, especially when you are in training centers, and it also improves your perspective and your surgery quality improves. Although as Vijay said, that sticking to one and doing it reproducibly will gradually improve that approach and make it more is safer for your patient, and you keep improving. But keeping the other helps you in difficult situations, in learning scenarios where you are in a teaching institute.
Thank you. Nikhil,
Okay, what is your opinion about layering it or taking as one flap? What you would like? What is more scientific or user
there
friendly?
is a lot of literature, but over the years in my practice, especially in a fractured neck of femur situation, it is very easy once you elevate the gluteus medius off. It is very easy to go underneath using blunt dissection or a swab or a Cobb's elevator, where you can very clearly see the gluteus minimus and the capsule. And it just makes you more meticulous. And you can either, do the gluteus minimus dissection separately, or if you want a good bulk, and if you are doing a bipolar, I tend to make an incision through the minimus and the capsule and elevate both the leaves and keep them out of the way. And when I do the final reduction, I close it. So that is the answer to a bipolar situation and a fracture neck situation. In an osteoarthritic situation, in a big patient, an obese patient of very, very large heads and cups, I tend to take like a flap, which is a very, very thick flap. Because sometimes you cannot get that plane in very, very contracted, hips. So I think it's horses for courses. So you got to look at, palpate, and every patient is different. But if you do it in layers, and I always like Vijay's approach because everything is meticulously done. And the same can be done for a lateral approach. Everything is meticulous in layers. You go open in layers and you close in layers. Absolutely meticulously. And, the success is guaranteed with that.
Even in the posterior approach, the same issue comes like Dr. Ranawat, who insists that it should be raised as one flap and as long as possible, almost from the bone, so that you reattach from where you took it off. Whereas Dr. Gherke at Endoclinic, he does a layered one and he incises the capsule separately, takes a separate stitch on the capsule. So I think both are reproducible and what works for one.
Yes. Nikhil, any points?
No, I don't use the direct lateral approach very frequently, but I had seen it being done in the UK and I wasn't really very happy with it. When I was training in Canada at ONA and Sunnybrook, I saw Dr. John Cameron do a very beautiful transgluteal approach. And what he did is he took the anterior 1/3 and the posterior 2/3, so that less of the abductors were devascularized. And then, like you, he meticulously identified the minimus tendon and took it away. And then he did a capsulotomy. And then in the end, he always took care to repair the capsulotomy very, very meticulously. And then the layer of the muscle that you have taken, he was repairing that also meticulously. So what I've done is modified that to repair the layer of muscle through the bone. And if I have to take off the anterior 1/3, I take it off with a sharp dissection with a flake of bone. So that is called as a Stracathro modification of the Dahl approach. The original Dahl approach was 2 anterior and posterior flakes of bone. The Stracathro modification, the Stracathro is a place in Scotland. That's where I first learned it. It's just the anterior flake and then I repair it to bone. But my only indication really is a neck of femur fracture. If I have to do, in a very unwell patient, if I have to do like a monoblock hemiarthroplasty or something like that. And that situation is rare nowadays.
Thank you. Is Vijay still there?
Yeah, very much here, Kiran. Yeah.
Vijay, any points to add to the approach? I know you're a posterior surgeon, but you have also done it in your training. So what are your thoughts?
As Nikhil said, very much in the same boat. Occasionally we use it for hemiarthroplasty. But then, when you repair the capsule, it's the posterior approach also, it becomes equally stable. Yeah. So we used to, in fact, for a long time I was doing my hemiarthroplasties through the hard edge because of the published, but we haven't had any dislocations. Now we do it posteriorly as well, because one thing is the team is, most of the hemis I don't do, so my juniors do, and because they have only seen me do a posterior approach, it's difficult for me to let them do a direct. That's the reason why they all do posterior, and we haven't had any dislocations, so also works good.
Kiran, just one advantage of Harding, which I wanted to point out specifically, was that you don't tend to lengthen too much. It's very useful in fracture neck of femur. But when you're doing through posterior approach, you want more stable hip. You end up lengthening the limb a fair bit sometimes because the capsule is very lax. It's not an arthritic hip. So for the hard hinge approach, you don't tend to lengthen much. Usually, that's my reason for choosing hard hinge approach. I use it only for fracture neck of femur because I don't want any too much of lengthening.
Absolutely right, and invariably you do not touch the posterior capsule, and that is important aspect in this approach where you cannot lengthen it too much, and also it gives you that inherent stability by retaining that posterior capsule. And regarding the flaps in osteoarthritis, very deformed hips, it's very difficult to get that plane between the medius and the minimus, but it is invariably seen in the fracture neck situation. And I've done many revisions also through the direct lateral approach as published by Lombardi and his team. But because I'm well versed with the posterior approach, and if I have to plan an ETO, then certainly I will choose the posterior approach. In revisions, when you anticipate it that you're going to use it. Other important point is that the repair, like Vijay said, is crucial. So if you do good repair, in a hard hinge approach, or if you do a good repair in the posterior approach, there is no dislocation.
So what are your landmarks for femoral offset restoration for anterior? What would be like?
In fact, it is, so once you position the leg in the pouch and gently externally rotated, you get a fantastic view. So you can see everything is right, the greater trochanter. You can actually also see the lesser trochanter very clearly with this position. And so in an osteoarthritic scenario, I always measure with a ruler using the tip of the trochanter and the center of the head. And when I do the osteotomy, it is very clearly visible. So when I do the trial stem and the head, I measure it again from the tip of the trochanter, from the tip of the lesser trochanter. It's all very clearly visible. Nothing is hidden. So I think it's a great approach because acetabulum is beautifully seen and the femur is beautifully seen. The only thing is the draping is very important. That pouch is very important. The sterility is very important. And you have to be aware of these things also. In the posterior approach also, you've got to be careful. If the assistant is holding the limb, it can touch his face or his chin or his mask, and you've got to be careful if he's not wearing a hood. So you have to be careful and aware about it at all times.
And another point which I think most of us did not mention is the abductor lurch, which lateral approach surgeons always say it doesn't exist, but a lot of it has been reported in the literature.
Yes. So as I said, the repair is the key. You're going to spend your time elevating the cuff from either side. Do not hesitate to use osseous bites, intermittently. Do not hesitate to oversew it. And I always see and palpate every case and see how it is. If I get a good cuff, then only cuff-to-cuff repair. If I think it is very tenuous, sometimes you can get what is called as a rotator cuff defect of the abductors, where you can see a small rent in the abductors. And in that case, I always make sure I elevate a lot of bone along with it using sharp osteotomes like a femester technique. And the flap of the abductors with bone is elevated off anteriorly. And when I close it, it is a very secure, strong closure. And I think I've never seen a lurch in my patients, probably because I spend a lot of time, developing the approach and learning it properly and then doing it meticulously. But yes, in literature, it is there. I don't deny it.
Now that you mention it, I think I'll ask another question to both you and Vijay about the degenerated abductor tendons, which you find a lot of times perioperatively. How do you deal with them, both to you and Vijay? Degenerated abductor tendon, because that's a kind of a challenge. A lot of times the hip is normal, it's the abductor tendon which is causing the pain in the hip.
Yeah, I mean, there's a paper out there about rotator cuff defect of the hip. The thing is, see, when you take the skin incision and when you look at the x-rays before you operate, there are some clues that, the abductors may be a bit deficient. You can see some spurring, some subtle signs there. But if you plan your skin incision in such a way that it's flexible, you can, on the table, change to a posterior approach if it's a very bad defect in the abductor. But many times the rent is not that big, And if you take a osteoperiosteal sort of elevation of the abductors, so you can take a box stitch and repair that rent, and then take a sort of a suture along the tendon and get a good repair. So it can be done, but if it is a very, very big rent, then you change your approach and go to a posterior approach.
And the important thing is to roughen the trochanter. If you see that rent, you have to roughen the trochanter, and then you try and repair it through bone.
Yes.
One or two occasions, it was completely detached when I went in, and it was retracted as well. So I had to use something called the Lars tumor band, which you must have seen. It has got it's like a sheet. It comes in different shapes and sizes. There's a Y-shaped one and there's a sheet. And in at least 2 cases, I had to use that in order to try and repair it. And the healing is by fibrosis.
Yeah, I've seen only one mesh being used when I was in the UK, but I never had the opportunity to use that.
So this is, minor tears are not an issue unless the patient had trochanteric pain before, had, like a rotator cuff of the shoulder. In a youngish patient, we tend to use suture anchors and things that's pretty straightforward, same principles as the shoulder. But more commonly, we see a ball trochanter in revision surgery. That's a much more common scenario that we see.
Yeah.
And my threshold for doing a gluteus maximus transfer is very low. So irrespective of whether the patient had instability before or not, when I see a ball trochanter, I would automatically do a gluteus maximus transfer on it automatically. And we use our ordinary Prolene mesh that they use for the hernia repairs, available in all ORs. And it works very well. We've got a large series of that. Then again, heals by fibrosis, as Nikhil said. And basically, ball trochanter worries me, no matter what approach you use. And I would use a thing to do a gluteus maximus transfer. Threshold is very low.
If the trochanter is bald, your approach is done.
Sorry?
Yes.
If the trochanter is bald, your approach is done.
Yes, that's true as well.
So any one of the panelists have ventured into DA or other?
No, I'm very, very old fashioned. I'm probably the only one in this panel who still believes in cement. You think I'm going to change to DA? So I always compare a hip surgery career to. I compare it to playing a test match, and you have 2 innings. I think I'm probably at a stage where I'm finishing my first innings and starting my second innings. And in the first innings, if your bat has worked and you can, stay on the pitch and you can score runs slowly and steadily, then in the second innings, why do you want to change anything? I'm not going to change anything.
I did critically look at it, being a high volume hip center and a lot of trainees. I went to various centers, high volume centers. I was not convinced that it gave them any advantage. And the so-called experts are struggling for my eyes. And I was said, okay, there's no way I'm going to adopt that.
Correct. Now, I've done the same as you as well, Vijay. In one center, I saw 12 cases being done on the same day. And on that one day, I saw 1 acetabulum fracture, 1 femoral fracture, and 1, you'll not believe this, 1 division of the sciatic nerve through the DAA. And I didn't believe that could actually happen. So I came back very disillusioned. There's no need. I know. I don't think there's any need. If something works in your hands, and if Vijay has 2 dislocations in 4,500 patients, and his patients are not limping and they're happy, why do you want to change a winning formula?
That is one. And the super path, anybody from the top, the posterior.
Again, you can make it comfortable. Like what Ranawat says, there are all difficult ways to do a simple operation. I think that's the best conclusion of that. It can be done, not that you cannot do it, but what are you trying to achieve here?
Yeah, also, I'm a pelvic surgeon. I do lots of acetabulum surgery. I'm used to big incisions. I just cannot see things through a tiny incision.
See, the other thing is that, if you are, like I have seen some live surgery with a direct anterior approach, and I saw, complications happening there. And like Nikhil said, the purpose of this conclave is very, very simple. We are looking at the audience who are 5 to 10 years in arthroplasty, and the 2 workhorse approaches in the registries, in literature, are these 2. And it is not a debate. In my talk, I said, if you want to be a hip surgeon, then the posterior approach you have to master. But if you want to be a well-rounded hip surgeon, then the direct lateral approach also has its place. And both have to be done meticulously well, and you have to improve every time you do the approach.
Yeah. See, I think the hip replacement is a fantastic operation. It's an operation of the century. We are reaching a stage where now we can publish 50 and 55-year data. So if somebody wants to learn hip replacements, he should focus more on how to fix the components really well and how to make sure that his hips last for 45, 50 years, rather than bothering about how he's going to enter in the hip joint. Also, the three principles of any exposure is your access, your extensibility, and then comes your cosmesis. And with a DAA, I don't think you get good access. I don't think you get good extensibility. And yes, arguably you might get good cosmesis, especially if you use like a bikini incision to do a DAA. So it doesn't satisfy the criteria of a good exposure for my criteria.
And another major concern about DAA is the cost. You need specialized tables, you need specialized retractors, and you need.
You can do it. You can do it without specialized tables as well. I went and watched that as well in Virginia. I saw 2 surgeons who do it just ordinarily without any table. But again, I was not really very enamored by it.
More assistance. You need more assistance with that.
Yeah.
The posterior approach, Vijay, have you ever in between tried to save the piriformis and try to, or you?
That's what I've mentioned. Yeah, we did try this pair approach. I've tried everything there is, but as Ranavat says, piriformis, even though the acetabulum can be exposed very nicely, if you retain the piriformis tendon, your femoral entry is skewed.
Yeah, correct.
And then you struggle in the acetabulum, and then you finally do the femur, you take it out. So all these maneuvers, it doesn't make any sense to me. Yeah.
And if you don't take it out, it rips out.
That's right. Then if either you take it out or you rip it out. That's the right way of doing it.
Once it rips, you can't even repair it properly.
There's just one point I want to make in the posterior. I've done this guy. He's a US guy. I've done a standard hip on him, 36 ceramic head and a poly liner. On Amazon Prime, on the 14th of this month, they released a series called as Eco Race. It's the world's toughest race, and he's a participant in that posterior approach, standard THR, and you must see that serial to see him. His name is Jason Magnus. He comes in many clips of that, and the things that he puts the hips through, really worth watching and getting inspired by. It's known as the Eco Race. It's now on Amazon Prime.
I'll just narrate a short incident. So we had this pilot he's a Su-30 pilot, so who walked into our army hospital and he was limping on a stick. He had a posterior fracture dislocation of the hip fixed somewhere, and then it went bad. It was bad arthritic hip. He was 23, and we did a ceramic on ceramic with a posterior approach for him. So it's all about that. That's what we say, that we think that there is restriction needed in arthroplasty, which I think gradually has gone away, even for the posterior surgeries. This guy, I told him, okay, I'm going to change your aircraft. Like, it could be a fixed wing because he didn't tell me anything. He got his hip done. He went back and he came back after a year and he's reflighted into the Su-30s. He has done a 9-foot jump. He's done we call it the frog leg walk. And then everything possible which could dislocate, which could break a ceramic on ceramic bearing, he had done. So I shouted at him, at least you should have told me you're going to do that. I would have put a ceramic on poly to be on the safer side. So now we already are in an era of high performance hips. The metallurgy is superior. The positioning is more accurate. The surfaces are giving us the outcomes. And we have been able to reflight many pilots. He was the first example which we did, whom we reflighted as a Su-30 pilot, and he still flies. So
the highest performance hip is the hip that lasts 50 years in a young person. Until something changes that, it's going to be very difficult to convince me.
Absolutely. So I think that actually brings me to announce to all who are watching and to the panelists that on Sunday we are lucky to have Professor Ross Crawford from Australia, who is going to take us through the 50 years of the Exeter hip. It's on Sunday, 30th of this month at 2:00 Indian Standard Time. So I, extend an invitation to you that, we will see from 50 years of the Exeter hip, and then we will have our usual Tuesday meeting following that on the 1st of September. So I would like to conclude this meeting by thanking Vijay for his sharing his expertise with us and meticulous surgery. Nikhil, Narendra, Surendra, Vikas, and all the audience. Thank you very much.
Thank you.
Thanks, guys. Take care.
See you then. Bye-bye.
See you, Nikhil. Catch you later.
Bye. Bye.
Bye.